where illegible handwriting turns medication orders into guesswork, and even legible paper, they fade or they disappear entirely. When something goes wrong, when something goes wrong, the nurses become liable. We know this story too well. Just like multiple sclerosis, the damage is first invisible until it becomes irreversible. Now, to the solution. The treatment for someone with multiple sclerosis is not prayer or hold remedies. Modern science has developed disease modifying therapies such as immunomodulators. In the same way, the solution to poor documentation is not more paper or hope, it is electronic medical records. My essay proposes a practical nurse led EMR system in which tertiary hospitals adopt EMR first to reduce cost, with a senior nurse serving as the monitoring lead to ensure compliance and education. A 2025 study in Ogun State, here in Nigeria, found that 28% of practitioners across hospitals in Ogun State already rely on EMR. So, this is not a science fiction, it is already happening and it is modern science. It means that it is possible. For secondary and primary facilities, the documentation unit can begin with daily chart audits, which can bridge the gap until they are able to adopt EMR fully. Now, let us talk about the implementation. Just like the treatment of multiple sclerosis, it is done in multiple steps of diagnosis, induction, and maintenance. Our EMR implementation must be coordinated as well. First, clinical nurses must recognize that we are the profession most affected by poor documentation. This should inspire us to lead a nurse-driven research in, to quantify the harm and to model the benefits of a structured transition to electronic system. Then we can present our findings to the Nursing and Midwifery Council of Nigeria. The council can now convene key professional bodies to draft a multidisciplinary policy recommendation, which will then be submitted to the Federal Ministry of Health. Fortunately, we are in a period when the Digital Health Bill of 2025 is already before the National Assembly. This creates a legislative window for adaptation, meaning that if any nurse-led policy change is to be considered, the time is now. Let me address possible counter-arguments that we may mention. We may be thinking that we stakeholders accept nurse-led interventions. This is this is a credible question. For this plan to work, we need four groups to agree: nurses, hospital administrators, the other medical practitioners, and the Federal Ministry of Health. And if nurses can convince them by leading the research and advocacy, as earlier mentioned, the key stakeholders will have no option than to be inclined to accept. Some may also say that that Nigeria is not ready because we have electricity issues, we have digital illiteracy problems, we have network problems. This is correct. However, my proposal already accounts for this. The treatment of multiple sclerosis was doubted before it became standard. In the same way, if we start gradually with a structured system that involves the tertiary institution first, this will make it feasible, reducing the cost of full scale rollout. In conclusion, judges and listeners, today again, May 30th has shone a red light in support of people battling multiple sclerosis. The world refuses to let this disease stay invisible. My essay asks for the same light to be shone on poor documentation. I have advocated a nurse-led solution to a quiet killer. We are change agents. And where the world that we keep changing, keep asking for change, no one can give that change better than change agents. Thank you.
Thank you very much, Mr. Olayinka. That was a good one. Ma, do you have any questions for him? Ma, we can't hear you.
Can you hear me now? I think every other
I think every
participant
other
can ask.
participant can ask.
Oh, okay. So if you have any
Yeah.
question for him, please raise your hand.
You should be able to ask yourself questions.
Okay, Miss Ogechi, please go ahead.
I'm not a
I'm
participant.
not a participant.
Is that okay if I
She's
ask
what
questions?
she's Yeah, go ahead.
Yeah, go ahead. Okay. Thank you so much. Thank you, Sunday, for that really impressive presentation. I have a question. I was a little bit confused with the mixture of multiple sclerosis and appropriate documentation. Is there any reason why you clumped it together? I know you're probably trying to drive a narrative, but I think you kind of buried some of your documentation. I mean, some of your presentation. This is my suggestion. But if you have a reason why you preferred it like that, maybe that will help me understand.
Okay, so before he answers, I am going to introduce this person that just asked the question. She's the president of Nigerian Canadian Nurses Association. So we are very privileged to have her here with us. And thank you very much, Ogechi, for being here. Yeah, so
Thank you so much.
To the contestants. Will you mind going ahead to answer that question, please?
Thank you, Ma. And thank you so much. It is a privilege to have been asked a question from someone with such status. To answer the question that has been asked, today is World Multiple Sclerosis Day, and it happens to fall on the same day that we are having this call to propose nurse-led solutions to basic problems within the clinical practice. However, while there is no direct connection between multiple sclerosis and the problem that I've identified, I have only used this platform because this chance that we have had, we cannot have it anymore. If we are going to have any other one, it's going to be another competition, and we may not have the chance to talk about this condition. I mentioned earlier that there are about 2.8 million people living with this condition, and this is the only day in the year when their condition is recognized, where people support and shine light to their condition. And in my presentation, I have done some parallels that can be said to be a link between this condition and how poor documentation affects us as clinical practitioners. Thank you.
Thank you so very
Okay,
much.
that is still not clear for me.
That is brilliant, actually.
Go ahead, Ogechi.
Thank you so much. That is actually really brilliant, Tosin. Thank you so much. I was waiting for that. I was waiting for that connection because I was really, really confused. But now that you pointed out why you wanted to do that or why you did that, that is really good. Thank you.
Okay, so Tosin, can you hear me?
Yes, I can hear you, Ma.
Okay, can you give us two instances where have you treated any case of multiple sclerosis? Even while as a student, have you been opportune to see anyone suffering from multiple sclerosis? And what impacts do you think multiple sclerosis have on not just the patient, but the family and not just the patient and also the family? Do you think this multiple sclerosis is something that the government should dive into and subsidize treatment for them also? Thank you.
All right, thank you, Ma. Multiple sclerosis is a disease where the immune system affects or attacks the myelin sheath of the neurons, affecting the transmission of signals and impulses uh, to to the brain and within the central nervous system. This condition brings about mobility impairment. It also affects sight and vision and other complications that are associated. And these conditions that I've mentioned, we can see that it makes a patient vulnerable. It can reduce productivity and it can cause some psychological implications to the patient. Without family support, without community support, the disease itself is already having a toll on the patient. So this is a condition that affects people severely with these complications that I've mentioned. So without proper treatment and support from communities like this from the government, it makes it even harder to to survive or to manage these complications very well. While I have not personally nursed a patient with multiple sclerosis on the ward, give my own individual nursing interventions, I still believe that it is what we can do, and it is something that we should be concerned about because we see ourselves as advocates, and we don't necessarily have to dwell on diseases that everybody knows. We must also consider some other diseases that have impact and people are not talking about. Thank you.
Okay, thank you very much. Moderator, over to you.
Okay, thank you,
So,
Ma. We have another question from, I think, can
I
we
think
take
there's
another
another
question?
question from the judges.
Yeah,
Yeah, the judges. Yeah.
okay, please go
Shoma, go
ahead.
ahead, please. Shoma, go ahead, please.
yeah. Tosin, please, can I see your first slide, your title page?
Thank you. I am working on that.
Can you share your first slide? Yeah.
Yes, thank you.
Your title page, your title page.
Title page. Next. Next. Yes, this is it.
Okay, thank you.
Okay. I think that's it for Tosin. Who's the next presenter?
Okay, so next person is Onoyibo Dora Latifa. Tosin, you can stop sharing your screen now.
Hey.
Onoyibo Dora Latifa.
I'm here.
Okay. Please, you have 5 minutes. Let's be very conscious of our time. We can start.
Good day, everyone. My name is Onoyibo Dora Lafino. I'm a student of Niger Delta University, 500 level student, and my topic is nurse-led emergency obstetric triage and autonomous interventions. So I'll be talking about this essay is focusing on the nursing roles in general, and I'll be focusing on what I encountered in my clinical posting as a nursing student. So first of all, I'll be talking about the first case of a footling labor, pregnancy that was a labor that was a labor that was presenting with footling, and this labor required an immediate C-section. And for the fact that this labor required an immediate C-section and the woman was already in a serious emergency, the nurses could not actually do much because they were waiting on the doctors, the physicians to clear a room which has already been booked for another CS. It was not an emergency CS, it was an elective CS. So this room needs to be cleared, at least shift the previous CS, the previously booked elective CS, so that this emergency CS can be taken there and everything will be done. But because of the fact that nurses in this facility, because of hospital policies, they were like handicapped in this situation because they could not actually do much. They were waiting on the doctors to do the needful based on what the policy authorized them to do. Now, while this situation was going on, there was a delivery also going on in the labor ward in the labor ward, where a woman who just delivered, was having hemorrhage. Now, for the fact that the woman was having hemorrhage and there was an emergency going on right now, the doctors have to leave the woman who has an emergency to focus on this other woman. The doctor have to leave the woman who they just delivered to focus on this current emergency, while the nurses couldn't do much. They were just doing the normal documentations and waiting for orders. Now, this is a situation where the nurses have rights to actually clear up this emergency room and demand this CS to be carried out immediately because it was an emergency. But because of hospital policies, like I said, this CS could not be carried out because we're waiting on doctors who are already on run for the booked CS, but nurses could not do much. And this could have led to a fatal or more serious incident of losing both mother and child. Now, in this situation, the doctors have to proceed to try to attend to the woman, which was too late because the woman pushed out the baby on foot length. Like she pushed out the baby. The baby had a tear on her perineal area. The mother has cervical tear, and you can literally see blood everywhere. Now, another thing I want to talk about. This is this case. So another thing now, the solution I am proposing with my essay is very, very free. It's zero amount. We're not paying anything for it. It's just to have an alignment. Let the nurses leaders that we have an alignment with this policy, with this ruling councils, the hospital management, the councils that organize and implement this policy that is binding nurses down from doing what they were taught to do. Because I, as a student, I was literally surprised about how these things play out in the hospital, and relaying it to what I'm taught in school as a student, it was not making sense. So I am proposing that these issues be looked on. Let hospital administrative work on these policies. Let the governing council, the nursing council work on these policies so that there will be a collaborating efforts where nurses don't have to learn and stock up their knowledge and not use it. I think I don't know if my time has ended. So this is the gap that I intend to bridge with my essay. Thank you very much.
Thank you very much, Ma, for that beautiful presentation. Ma, do we have any question?
I do.
It's
Okay, Ma.
okay. Go ahead.
Ma, please go ahead.
Okay. Thank you so much. That's Dora, right?
Yes, ma'am.
Thank you so much for that beautiful presentation. Yeah. Thank you so very much. The issue you identified, do you think it's more of a triad issue, whereby hospital management, they are able to triage appropriately to prioritize issues based on who needs help the most, or do you think it's a leadership issue?
I would say it's both a leadership and a triage issue, in the sense that the nurses in triage, relating it to triage issues, the nurses could have actually, they know what they would do in this situation, but based on leadership issue, they are handicapped to actually do anything. Now, based on triage issue, they have a severe case. Like, as a matter of fact, both of them are serious cases. But then, in triage issue, the nurses would have been able to prioritize what they need to prioritize first and do the needful, in the sense that if they are both, if the doctors, the physicians, and the nurses are in collaboration, they will definitely do the right thing and save both lives. And as a matter of fact, stops that woman from pushing too much and forcing the baby out, causing the tear and the emergency between both mother and child.
Thank you. So, thank you. I just want to get a very clear picture about this. So, but the nurses, they won't be doing the surgery though. Because the theater, right? Maybe it's to put if the theater was not free because there was another woman in the operating theater. Is that the case?
No, ma. There was an elective surgery for someone else, but the patient is not here yet. So it's not like they have already sedated the patient or anything. The patient was not there yet.
Okay, the patient was not in the, okay, they had an elective surgery, but now
Yes.
Okay, now I get it clearly. And now we have this emergency CS who should have been okay, I get it. Okay. Thank you so much. I think it's both. I think it's more of a triage issue, but if the hospital collaborated better, okay, they will be able to identify, triage, right? And then set the emergency straight. Because even if they are to send the woman to the theater, if there was no doctor, alerted based on the triage system, they still wouldn't do the surgery, right? It would just be making the theater room available, but then nothing gets done because there's no doctor assigned to do that, because they actually assigned practitioners based on triage, based on who is seeing who. Is that not the case?
Yes, ma'am. But then, sorry, the doctors were available. It's not like there were no physicians. The physicians were available. As a matter of fact, the anesthesiologist was there. So it's not like the physicians were not available. But the nurses they don't have the rights as per hospital policy to enforce an immediate emergency, like to enforce the fact that this, not like advocate for the patient, that this patient needs to go to this emergency CS immediately. So the situation became
let me cut you short there.
Yeah.
Are you saying that if the nurses identify that this person is an emergency, the nurses don't have the right to inform the doctor or the physician or the surgical team that we have an emergency and this have to be done now? Is that what you're trying to say? Or there was an emergency already in the theater and this emergency came in and they didn't have that opportunity to do that? Or there was a chance for this person to be taken into the theater, but because they had an elective CS, which the person wasn't even there, they preferred to wait for the elective and leave this one that is an emergency. Is that what you're saying?
No, what I'm saying is,
if I got you right.
Yeah, what I'm saying is it's not like they preferred to leave this one. But then, while the other one wasn't there, the nurses cannot actually force the physicians to do anything.
But they cannot. But they cannot force. Sorry, there's nowhere in the world. I'm trying to understand it. There's nowhere in the world where nurses can actually force physicians to do it. But yeah, it is actually because even if the way I'm looking at it is, you can have physicians around, right? But each one they have specific specialties and they have specific skills, and they work based on what they're assigned to do also.
Yes,
okay? So if the triage system does not come up, right, even when the theater is available, nothing gets done. I think I see what you're saying 100% in terms of refining that leadership and enhancing that collaborative space where nurses and doctors can work collaboratively, and also collaboratively, but most importantly, refining the policy with regards to updating the triage system in real time, right? In real time, yeah, so that it can be assigned to who does it. Who can actually perform that surgery effectively, and who needs that help at that point in time.
Thank you.
Okay, thank you very much.
Thank you so much. Thank you. I hope I didn't throw you off. I wanted just to clarify to understand what you're saying.
No,
I
ma.
think,
I think she was able to clarify that. Thank you.
Yeah.
Okay, over to you, moderator.
Okay, thank you very much. I have a question, but it's not for Dora.
Go ahead.
Should we be lenient with the time, because the first and second speaker, they use more than 5 minutes, so I should cut them off when it's exactly 5 minutes.
Yeah, when it's 5 minutes, just let them know. Let them know.
Okay. So the next person is Chielo Zombie Gizoma. I don't know if you're on the call. Gizoma. Sorry if I'm not pronouncing that correctly. Okay, person is not present. We'll move over to the next person. Blessing Wajoro. Are you here? Blessing Wajoro. Okay. Do we have Elijah Abraham? Okay. So, do we have Damisola Ajayi?
Yes.
Damisola. Okay. So before you start, the next person will be Zamtia Samalia. So you should be getting ready. After Damisola, you'll be presenting. So please, you have exactly 5 minutes. Thank you. 6:56, you should be done. Damisola, you can start.
Go ahead. Is she still there? Damisola, are
Yes,
you
she's
ready?
trying to share screen.
I'm trying to share my screen.
You're eating into your time. Can you start while you're trying to share your screen?
Okay. Good evening, everyone. I'm Damilola Ajayi, and I'll be discussing a very, very important. I bridge the gap between prevention and treatment in Nigeria's healthcare system. And so, for a while, when I joined the area of public health, I found out how malnutrition was the leading cause of death and disease and a major cause of death. So what the part that hurt me most was that I discovered that NCDs, which are rising, that is part of burden of malnutrition, can be prevented by lifestyle choices. And then Nigeria's healthcare system focuses mainly on the curative aspect instead of the preventive aspect. Okay, please, am I still, is my screen still showing? Is my screen still showing?
We can
You
hear
are
you.
trying to
We can
share
hear
your
you.
screen,
Yes.
I'm having,
but we are not
I'm
seeing
having,
anything.
You can go ahead and present without the screen.
okay, so when I discovered this, I discovered I had this other part. When I discovered I joined other parts. I joined other
Do you
parts.
want us to call the next person? Then give you time to sort
I joined
yourself.
other parts. My network was having issues. My network was having issues. Okay, good evening,
I don't think
everyone.
we can hear you.
Damisola, are you having network issues?
Yes, I'm having network issues.
Okay, so we'll move on to the next person while you sort yourself out. And before the meeting, you guys were informed to get a good environment, stable network connection. I don't know why, but we'll come back to you. So the next person is, I'm sorry if I'm pronouncing your name wrong, Zemtia Samaila. Are you on the call?
Yes, I am.
Okay, please, you can go. Oh, Samira, you can go on, please. I'm sorry, you have just 5 minutes. Please, let's try to keep to time. Thank you.
Okay. I want to try and share my screen, but I'm having difficulty sharing it because I don't really know how to do it. Can I just go ahead with the presentation?
Yes, please. You can go ahead.
Okay. Good day, everyone. My name is Emira Samaila. I'm a nursing student from University of Abuja. Today, I'll be speaking on the topic, Bridging the Gap, a nurse-led approach to improving patient care in Nigeria. There's a difference between healing and suffering. It's not always about medication. Sometimes it's about communication. In many Nigerian hospitals, patients do not only struggle with illness, but they also struggle with uncertainty, confusion, and lack of information about their care. Many patients go through treatment without fully understanding what is happening, why there's a delay, or what's the next step in their treatment. This gap between the healthcare delivery and patient experience remains one of the major challenges in clinical nursing care in Nigeria. One major cause of this problem is poor communication and care coordination. Nurses often work under pressure due to large number of patients and focus and workforce limitations. Because of this, patient engagement and clarity in care can sometimes be overlooked, even though they are essential parts of healing. This lack of communication can lead to anxiety, delay of patient care, and reduced trust in healthcare system. As someone living with lupus, I understand this challenge personally. I've experienced healthcare not only as a nursing student, but also as a patient. I remember sitting in the hospital for hours without understanding why my medications were delayed. It wasn't just the illness that affected me. It was the silence and uncertainty. That experience made me realize that patients do not only need treatment, They also need reassurance, understanding, and compassionate interaction during their care. This is why I believe that nurses should lead the solution. Nurses are the healthcare professionals who spend the most time with patients. They are the first people that the patients meet for comfort, for explanation and support. Beyond administration of medications, nurses often play important roles in communication, healthcare coordination, and ensuring patient voices are heard. Because nurses interact closely between the patients and other healthcare professionals, they are the best positioned to bridge the gap between medical care and patient understanding. To address this issue, I will propose a nursing-led communication and patient tracking system that is practical, affordable, and adaptable to healthcare systems in Nigeria. The first solution is implementing daily nursing and patient briefing. At the beginning of each shift, nurses can briefly update the patient about their medications, procedures, and treatment plans for the day. This simple step can help patients feel informed, involved, and less anxious about their care. The second is introducing simple patient tracking checklists. This checklist can help patients monitor medications, patient care progress, and outstanding medical cares. In a busy hospital environment, this can improve coordinations and reduce delay in healthcare delivery. Another important aspect of this approach is strengthening patient care.
Zamira, please, you should be wrapping up in the next minute. You should be rounding up in the next minute. Thank you.
Okay, and share responsibility among nurses through brief shifts handing over discussion. This discussion can help ensure that the responsibilities are properly transferred and no patient is overlooked. And this strengthens teamwork and continuity of care. In conclusion, bridging the gap in healthcare is not always about advanced equipment or complex systems. Sometimes meaningful changes begins with small actions, compassionate communication, and teamwork. Effective healthcare goes beyond treatment by ensuring patients feel heard, informed, and supported throughout their care. By empowering nurses to lead communication and coordinate efforts, we can improve patients' experience through trust in healthcare system and promote better healthcare outcome in Nigeria. As a future healthcare professional, we must remember that care for patients is not always about treatment of illness, but it's also about treating people with dignity, empathy, and understanding. Thank you.
Yeah, thank you very much for that presentation. Thank you very much for that presentation. That was nice.
Do we have any questions for Zamira?
That was so well done. So well done, Samira. Thank you so much. That was well done. So I have a question. I think I have an. I don't know if it's from me. So how would I know this? You've proposed how this communication is going to be passed, right? So how can it be? How can it be implemented into the system so it becomes part of the system? I don't know if my question is correct, right? Because we have so many recommendations and so many things hanging out. So how can it be? I guess what I'm trying to say is this: how can it move from just a thought or from recommendation into actual implementation?
Okay.
What do you, based on your experience?
Okay. Based on my experience, thank you very much for the question, Ma. Ma, sorry, can you come again with the question? I didn't really get it.
Okay, so what
Sorry.
I'm trying,
was
so
out.
what I'm asking
Okay,
is,
go ahead.
Sorry. Yeah.
how do you think this these things I don't want to call them recommendations. How do you think we can move from thoughts into system implementation? How do you, from your experience as a nurse, you're a nursing student, right? From what you're seeing
Yes, sir.
and from what you've seen in the literature, what do you think is the best approach, or even if it's not the best, what do you suggest are the avenues to be able to translate this into practice, so that it becomes a system whereby you know, a hospital can use it. You know what I mean? So it's part of their system
Okay.
and not just fall through the cracks.
Okay. One is introducing the tracking checklist. This will help the nurses to be able to know the next procedures and the next treatment for each patient. And also teamwork among nurses. I don't know if I'm getting whether what I'm saying is in line with what you're asking.
Let's go ahead. Go.
Okay. Then teamwork with the nurses. This will help for better cooperation and making the work faster and efficient for both the nurses.
Okay, thank you so much. Okay, I'll give you some insight. So what I think your recommendation is actually good, but the one thing that can easily have to put it into a system is it becomes, like you said, it becomes one of the checkpoints, right? Whereby nurses during handover, it becomes part of the to be able to put it into a process. Okay, now, such as, okay, have you done this vital signs? Okay, you know how you say, okay, I'm going to do vital signs 3 times a day, TID or BID. So that patient communication becomes part of the system, part of the process, whereby nurses, it becomes in their system. They say, okay, have you discussed with this patient about their problem? During handover, they can bring it up. Okay, have you talked to this patient about their problem? What concerns does this patient have? Okay, that would be part of the subjective assessments, right? And then to be able to put that into the system. Does that make sense?
Yes, ma'am.
Yes, thank you.
Thank you
Okay,
very
I
much.
think I have someone have a question before I give my contribution. Oluchukwu, go ahead. Go ahead with your
Hi,
question.
everyone. My question is to Samalia. So about your topic, bridging the gap in the healthcare sector, what strategies do you think can be used to improve communication with patients who have language barriers?
Language barrier.
Can I speak for her?
Sure, of course.
I won't allow her to answer that question. That is completely off, because that's a complete different subject altogether that somebody has to research and prepare. The person is not prepared for it, they're not going to say anything. So that is off. Sorry. Thank you.
Okay, so I think my contribution to that is you've talked about how nurses can be able to bridge that gap between, it's not all about medications, it's about you actually considering these patients. Because sometimes the patients are in the hospital and they are waiting hours to see a doctor. And sometimes the only thing they just want is for a nurse to reassure them. They don't just want to sit down there and be waiting for hours. They just want someone to come talk to them like, oh, the doctor will be with you soon or shortly. Or you even go ahead to find out as a nurse, we have expertise on how to find out what is wrong with. That is where triage comes in. What is wrong with when a patient sees that you are actually caring for them, when they see that compassion, when they see somebody communicating with them. You see, the problem with our healthcare system in Nigeria is we are just too free to the extent that we feel that we can just do it anyhow. Like, I don't know how else to put it. Like, in the system where it's working, you can't leave a patient for hours without attending to them. Like, you, even if they are waiting for the doctors, the physicians to come in, you as a nurse, you have something to tell them. You have something to do for them, even if it's just going there, checking their vitals, making sure that, okay, telling them, okay, reassuring them someone will be with you soon. That would give them that confidence. And that is why, if you, even when this patient have waited for hours to see a physician, at the end of the day, they take it out on the nurses, because you are the one with them there. They are not seeing the physician. And when the physician comes in, and when the physician comes in to take over, they are happy to see the physician. But you that have been there with them, they don't even mind, because first, you did not show professionalism, and that is something that goes on in the hospital, especially back home. That is something that, as a student nurse coming out of school, these are things you should be implementing. These are things you should be suggesting to the leaders to also put into policy. And also, if we have our nursing leaders as policy makers, when you, like in the hospital setting, most times you don't even have nurses as policy makers there. So these are things that we should be pushing forward, so that when more nurses are there, then we'll have a say at the end of the day. Thank you very much for that beautiful presentation. This is just my own contribution. Thank you.
Okay.
Back to you, Ojuma.
Yeah, ma'am, here. So the next presenter would be Sunday AJ Tibuka, after which we'll be having Kenneth Amen. So please get ready. Please, Sunday, you have
I think
exactly 5
Damilola,
minutes.
was it Damilola that was supposed to present?
Yeah, that had network issue. No, it was
I think
Elisha.
she was the one, right?
Damisola Ajayi. Yes, ma.
Okay, so if she's ready after Sunday, then she can go ahead and present.
Okay. So Sunday, please, you have
Thank
exactly
you.
5 minutes.
Thank you.
Please
Right.
give us your presentation. Can start. Mr. Sunday, are you there?
Do we have Sunday? On the
He was just on the call. Oh, if Mr. Sunday is not there, then Damisola, if you are around, if you are ready, sorry, please, let's have you. Damisola Ajayi.
I think Sunday is back. Are you ready, Sunday? We can't hear you. You're muted. Can you unmute yourself, Sunday?
Okay. Sharing screen.
I'm trying to share my screen.
You can go on.
Okay.
Please minimize your echoes.
Just turn on your camera and just go on. You don't need to share your screen.
All right.
Thank you.
Good evening,
And
Georgie. Good
Georgie.
evening,
Good
my fellow
evening, my fellow
non-time.
non-time.
I'm by
I'm
name
by name
Sunday
Sunday
Chibike
Chibuike
on
on
Department of Nursing
Department of
Science,
Nursing Science,
University of
University of
Maiduguri.
Maiduguri.
University of Maiduguri. I'll be presenting on the topic bridging the gap, reducing delayed antenatal care in conflict affected communities in Nigeria, a nurse-led approach. In Nigeria today, giving birth can almost feel like a death sentence. This is because of the rising maternal mortality that we share about 28% of global maternal mortality rate. And 74.8% of our women come first to the clinic after 12 weeks of pregnancy. And when they show up to the clinic, you see preventable complications such as anemia, eclampsia, hemorrhage, and neonatal death. The question we all ask ourselves is why? And it's definitely not that they are ignorant of this condition. But as a result of conflict that have destroyed so many health infrastructures across Nigeria, such as the prolonged Boko Haram insurgency in Borno State, farmers' herders crisis in Plateau and Benue State, and poverty that have made so many women not to be able to afford transportation costs to the existing facilities, abandonment in cases of multiple wives, stigma in adolescent pregnancies. As nurses, we can offer solutions independently to this existing problem. The gap can definitely be bridged with the introduction of mobile antenatal care clinics in the IDP camps. Though these women cannot be able to reach out to the healthcare facilities, but we can take these facilities to them. IDP camps is one of the most critical areas where most women don't attend antenatal care or even show up late only when humanitarian aids come there. So as nurses independently, we can take mobile health clinics to the IDP camps and take villages that have been ravaged with insurgency and conflict. Create digital platforms like WhatsApp group, SMS reminders, where pregnant women can be sent information and be reminded of their routine checkups. As nurses, equally, we can stand as advocates for our women. I could remember a story one of my mentors told me during her clinical posting on how a woman could not be able to afford a 200 naira for urine test strip. But they noted that this has been an ongoing problem, documented this, wrote to so many NGOs, and finally they got one that supplied them this material. This is practical example of a gap bridged as nurses. Community allies. As nurses, we can incorporate traditional birth attendants in most of these villages where healthcare facilities are no more functional. These women are left in the hands of traditional birth attendants who has little or no knowledge in management of obstetric emergencies. So as nurses, we can go to these villages, incorporate and train them, recruit health volunteers, and equally create a safe environment where adolescents can speak up in cases of adolescent pregnancies. Finally, the reasons why this needs to be implemented, we are the first healthcare contact of many of these women in the rural areas. And early antenatal care has been proven to prevent 80% of maternal complications. Yes, healthcare facilities might not be within the reach of these women, but we can take these facilities to them. We can care for them. We can prove that they are not sidelined in the society. And I will leave us with this quote. She did not need a better clinic. She need one person to care. As a nurse, I can be that one person. And I'll ask all of us, can we? So I have some nice pictorial representations here to show us what nurses individually can do. Maybe I will show us. Hello?
We can
Yeah,
hear
we
you.
can
We
hear
can hear
you.
you.
This is what
This
a
is
mobile
what a mobile
antenna
antenna
in IDP camp
IDP
setting looks like.
setting looks like.
And
And
individually,
individually,
when we
when we
take this
take
to
this
the
to the
communities,
communities,
these people
people
will
people
involve in the
involved
health
in the
care,
health care,
and it will
and it will
encourage them to
encourage
come
them
out
to
and
come out and
participate in the
participate
care
in
more.
the care more.
Thank you so much
Thank
for
you so much
listening.
for listening.
Thank you very much, Mr. Sunday. That was a very beautiful presentation. I don't know if any of the judges have questions or any of the participants. You can ask to you can ask our questions now. It's just 1 minute for each question.
Yeah. Yeah. Okay, thank you very
Okay,
much,
thank you very
Sunday, for
much,
that
Sandy,
beautiful
for that.
presentation.
It's
You asked us a question. I would like to put that back to you. Would you be that nurse? Would you be that one person that would go to those IDP camps? When you're deployed to that place, would you not go to any extent to make sure you're out of those villages to go into the city? Would you be that nurse? Would you present yourself that you want to work with these women? I want to be that nurse, that I want to be that one person that antenatal patient, that pregnant woman is going to walk up to, and the professional that would help. I want to be. Would you be that nurse? You have asked us that question. Let's point it back to you. So what are your
Thank you so
strategies
much.
for making sure that the nurses that are posted to these places stay there? Because it's not just by putting people there. People are ready to go, or people are not ready to go. But what do you think the government can put in place that will make these people ready to sacrifice themselves to go into these places and make sure that health is made available to everyone, and not just them not being able because they lack healthcare? Thank you.
Okay, thank you so much. Now, one of the things that motivated me towards this writing was I have to witness a mother that died as a result of complications. It came from one of these villages. And after that particular incident, I was moved. It gave me the passion towards preventing such incidents. Personally, answering your question direct, I would stand in the gap. And in regards to the provisions for nurses or what will help keep our nurses in place when we are posted to that, we will document this impact. We will document the impact of this thing, writing to the Ministry of Health and the state or federal government, as the case may be. Then security is a very important aspect. And for most of the NGOs, because some NGOs are already in the front line of this, they work alongside with the police and also some other agencies to ensure their safety. So once we write to the government, like the mobile clinic stuff is something that might be happening time to time. Maybe the nurses will visit this community once in a week. So we can take some police escorts as granted by the agencies to make sure that the safety of these nurses is being granted. So it's all about showing our willingness towards solving this problem. We write to the appropriate agency, and they will work with the nurses. Thank you so much, ma'am.
Thank you so much. Thank you so much. Does any other person have any question for you?
Any question for you?
Okay, over to you.
Okay, over to
Moderator.
you, moderator.
Okay. The next speaker should be Kenneth Emen. Mr. Kenneth, are you on the call? Kenneth Emen. Okay. Is Damisola now back on the call? Damisola Ajayi.
Yes. Yes.
Damisola, are you back on the call? Damisola Ajayi. I think the network is still very bad. Do we have favor or buy for? Or buy for favor?
Yes, I'm present.
Okay, please, you have 5 minutes for your presentation. Please, let's keep the time. 5 minutes, exactly 5 minutes. Thank you.
You're
You're
muted.
muted.
Okay, thank you. Good day, esteemed judges. Good day, host. Good day, my fellow nursing participants. I'm a 300 level nursing student, and I'm so glad to be here today. So, during one of my clinical postings, I encountered a case of a woman who went into unexpected labor. And I went to the cabinet to be able to get a sterile glove for her to be able to deliver safely, and there were no sterile gloves. So that incident led me to, yes, incident led me to choosing this topic for my essay, a nurse-led safety net for resource scarcity in Nigerian clinical settings. So there's a line in the nursing anthem that says, "We are the source of hope to ailing ones and the foundation for building a healthy world." As nurses in the present day times, we try our best to live up to this responsibility. But the problem is not that we nurses don't have the skills or the diligence. The problem is the lack of accessible supplies to be able to carry out nursing care. According to the 2023 National Health Facility Survey, less than 35% of primary facilities have essential drugs and resources available. So, why does this matter? This matters because lack of resources compromises patient safety, it increases nurse burdens, and it increases nurse burdens, and it also reduces patient trust. So I came up with two solutions to this problem. The first solution, as you can see on my screen, is a 1-week safety net. So the 1-week safety net is a nurse-led emergency preparedness system designed to ensure immediate access to essential medical consumables. I'm just going to quickly explain how it works. So I have a pictorial representation here to be able to aid that process. First, the ward supply committee is formed, and then 5 consumables are selected. For example, sterile gloves, syringes, gauze, IV sets, and surgical sprays. These consumables are selected, and then the ward supply committee partners with local communities and NGOs to be able to gather donations. And these supplies are then kept in a supply cabinet so that when these emergencies occur, the nurse can quickly go and get these supplies and then sign out in a logbook to ensure accountability. This ensures that nursing care is quick and prevents delays that can lead to harm on the patient. The second solution is the Sister Ward Mutual Aid Compact. So it's a structured collaboration system between nearby hospital wards that allow for rapid sharing of emergency supplies during shortages. So this is between sister wards, and it can serve as a secondary backup to the 1-week safety net. So how does it work? I have another pictorial representation. The missing or the resources that are in shortage are identified. Then the sister ward contributes resources to be able to create a backup. Now, these resources are kept securely in a matron's office or wherever they have agreed to keep it, so that when there are emergencies, any nurse from each of the wards can go get those resources, sign out in a logbook so that the resources can be accounted for. Then monthly reports are conducted so that it can prevent theft and promote trust. If these two solutions are implemented, it can lead to a lot of impact. For example, shortages should be able to be identified early on, emergency supplies will be readily available, patient safety will be improved, and there will be better monitoring system. In conclusion, these ideas are nurse-led, they are practical, they are low cost, and they don't require major policy changes to be able to put them in place. So these are the next steps that we can take to be able to ensure that these things are implemented. When nurses lead, patients are protected. Thank you.
Thank you so much, Ma, for that beautiful presentation. I don't know if anybody has questions for her. Any questions?
I have a question.
Okay, Ma.
Thank you so much, Favor, for that. So for this approach, this scarcity, at what time do you think this can happen? I mean, the scarcity of supplies. At what instances?
This can happen where there are delays in the normal procurement procedures. For example, there is a normal store where resources can be gotten, but sometimes in most hospitals, the processes to get these supplies take a very long time, and if delayed, it could lead to lower patient safety. So this idea that I propose is just to cut the amount of time it takes for nurses to be able to get these resources, and so that they can be able to carry out their nursing care effectively.
So is this unit specific or the entire hospital specific, General? Is it the entire hospital system, or you're talking about unit specific? And if it is hospital, how would they know? How would that information be disseminated that they have the supply, this contingency supply here, and then who will be in charge of it? I know you said the matron's office, but
yes, in my idea, I said that the award supply committee will be formed. So there will be a committee especially for creation of emergency reserve. And then it is an idea that is practical. It can be implemented in all the wards because it can be implemented across all the levels of healthcare, because it's based on principles such as accountability, community participation, and so on. So these things can be done across all levels.
Do you think it not result in hoarding?
Yes, it could.
Exactly my question.
It could result in hoarding. That's the reason why a committee has been set specially for it, according to the needs of a ward, according to the capacity, according to the level of work and business that happens in a ward. The emergency reserve, there will be a set amount of resources to be kept to prevent issues like this.
Okay, thank you so much.
Thank you very much for this presentation. Have you seen instances where these things are provided and the matron that is supposed to be in charge of this provisions. At the end of the day, goes ahead to send it to this patient.
I've not seen
even call and take it and themselves take it to their own clinics to use on their patients. So how do you think that can be managed? You can't take away hoarding.
Yes.
Right.
For this important question. Well, curb issues like that. That is why the sign was screened. In the log, the amount donated, the amount how emergency will be recorded, and then that is done at any instant or any point in time. And during the month reviews, He can sit down and evaluate whether the total of much. This helps to prevent theft and issues like hoarding because the committee will be present and the donors and stakeholders also be present. Any irregularity treated in that review.
Thank you. Yeah. Thank you. I think that's it.
Okay. The next speaker is Alaide Ramat Kainde. If we have Paul Udobe Etim, please get ready. You'd be next after Kainde. So do we have Kainde on the call?
Yes.
Alaide. Okay. I'm so sorry if I'm not pronouncing your name very well. I'm so sorry. So please, you have exactly 5 minutes. We really have to stick to time for your presentation.
Okay.
Thank you.
Okay. Good morning, good afternoon, good evening, everybody. My
Can
name
you
is
please
Alade
mute
Kende
if you're
Amotalai,
not
a student
speaking?
of Lagos State College of Nursing. Oh,
Go ahead.
okay. Can you hear me now?
Yes, go ahead.
Yes.
Go ahead.
Okay. My name is Alade Kende Amotalai, a student of Lagos State College of Nursing, Uganda, Lagos State. Hi. My topic for today is when pain is ignored, bridging the gap in compassionate pain management in Nigeria. I chose this topic not just because it is a clinical issue, not because it is a clinical issue, but because it is something that I've experienced personally. I've seen situations whereby pain are being dismissed, and especially like dysmenorrhea. I remember a day when a colleague of mine collapsed in pain due to severe dysmenorrhea. And when pain was sought, everyone help was sought. I think our response, the person response was rather very casual, and it was more like, isn't it just dysmenorrhea? I understand what just dysmenorrhea feels like. I am spending every day, it's the entire day, entire hours, waiting for the time to pass by so that the pain can go. And this is not just happening for only dysmenorrhea. We have other issues like this. The problem that we are facing, isn't it just dysmenorrhea? Pain because it is normal, and we experience people like the women who are told that to endure pain, menstrual pain, and labor pain because it is normal. Sickle cell patients are accused of exaggerating or lying because of repeated visits to the clinic. And also, post-operative patients lies awake in pain with no checks in. And pain that is seen but it is not believed are reported but not acted upon. The root causes of this cultural belief. Most parts in Nigeria, we believe that the moment that you can bear pain, it means it is a sign of strength. And it's not every healthcare personnel that will ask you about your pain or that will be able to easily know that you are in pain. Staff shortage, which is one of the most common causes that we are experiencing in Nigeria today. Nurses are overwhelmed and they barely have the time to assess every single patient. Underuse of pain tools. We have the numeric rating scales and the Wongs-Baker faces scale, which are rarely used, or in some cases, they are not even available at all. We have poor documentation. And in every procedure we do in our procedure manual, there's always documentation. It shows that as a nurse, we have to document every single procedure that we perform. But in most cases, we see when a patient complains about that pain and it gets lost in between shift and handover. It stops picking up. Then they report their pain to you and then you just dismiss it. They'll assume that since they've reported their pain to you, then there is no, and you are not doing anything about it, then there is no need for them to talk about their pain. The consequences of when unmanaged pain is not being managed. It doesn't just cause only physical suffering. It can also slow down the recovery and healing. A patient that is suffering from pain, there is an increased release of cortisol, and cortisol can affect how the immune system is going to heal the patient or is going to fight against infections. causes anxiety, distress, and sleep disruption. It also wears down a patient mentally and emotionally. I use myself as an example who has always experienced severe dysmenorrhea. Whenever my period is coming, I fall into depression because I know that the thing I'm going to be feeling is going to be severe. And if I have anything important to do, I know that the thing is going to be set aside, or I'll not be able to do it well because of the severe menorrhea that I'm going to be having when my period comes. It breaks trust in healthcare system. When a patient tells you about their pain, but instead it is being dismissed, then the reason to tell you how they are really feeling will not be there. It causes patients to stop taking care until it's too late.
Please, you should be rounding up now.
And when they do not tell their feelings immediately. By the time they come to the clinical area, it is now, and it's not easy to manage. Now, this is what the solutions I have. You have to assess their pain consistently and honestly, and use the tools that we have, like the numeric rating scale, and also the motivation scale at every interaction. And believe your patient. Don't assume that they are lying. Pain is subjective. It is your patient that is feeling it, not you. And document accurately, which is very important. Communicate with compassion. Like my colleague that was, our pain was being dismissed with, isn't it just dysmenorrhea? It could work more as, tell me about what you're feeling. Do not remember the medications that you're giving. Instead, they remember how they are being treated. Advocate for patients. When a patient complains to you that they are having pain, escalate the matter to the other medical team. And also, if the medication is not available or use non-pharmacological methods like positioning, relaxation, and also educate your patients to pick up aid. My closing for today is, pain is not weakness. It is not drama. It deserves a real human response. Every patient who enters the Nigeria healthcare facility should leave feeling hurt, not dismissed. As nurses, we have the access, the training, the art to bridge this gap. One patient, one conversation, one act of care at a time. Thank you very much.
Thank you very much, Ramot. Any questions for her before we move to the next speaker?
Thank you so much for that presentation. Mine is just like a contribution, not a question. So the thing is, when it comes to pain, we should know that pain is whatever the patient tells you it is, and not you judging from your personal experiences, or you thinking, oh, you don't assume. When it comes to pain, pain can be emergent. So when it comes to pain, it is what the patient tells you that pain is. That is what it is. And that's why you as nurses should take initiative. That when a patient is telling you, okay, I'm in pain, we have different rating scales for you to rate this patient's pain correctly. Either you're using the 0 to 10 scaling, or you're using the facial grimacing scaling, or whichever one you're using. Make sure that you rate the patient's pain accordingly and not assume, because assumption has put so many, especially when it comes to some patients, you take them, they are not emergency. Like here, when it comes to chest pain that people joke with back home, I think we lost one of our matrons because of somebody just called it just chest pain. She was rushed. This is a nurse. She was rushed into emergency, and she told them she was having chest pain. And they told her it was just, they said it's just chest pain. And within few seconds, they lost her. Here, when you have chest pain complaint, the person is treated as an emergency until you rule out every other thing. So I think we have to pass that narrative. We as nurses, we have everything it takes to pass that narrative. And we are the first call for every patient. When patient comes to you and the patient is feeling pains, don't dismiss the patient's pain. Go ahead to check, see what you can do for this patient, and make sure the patient is attended to urgently. That's just my contribution. Let's never dismiss anybody's pain. Pain is what the patient tells you it is. Thank you.
Thank you very much, ma'am. Thank you very much, ma'am.
So we're going to move to the next speaker, Paul Udobe Epping.
Present.
Okay, thank you. Please, you have exactly 5 minutes for your presentation. Please go ahead.
All right, thank you. Thank you. Endeavor to mute so that I will hear very well. All right. So first of all, I want to
Mute if
thank
you're not
the
speaking,
organizers
reduce the echo.
thank you. I want to thank the organizers of this competition, Dynamic Nurses Skill Initiative, the NOSA president, and of course, the president, Nigerian Canadian Nurses Association. This is a privilege and an opportunity for us nursing students to give in a take on how we can improve the healthcare sector. So my name is Paul Uboetin, and I'm from University of Uyo, and I'll be speaking on the topic bridging the gap, tackling inadequate continuing education for nurses in Nigeria. And I'll repeat that, bridging the gap, tackling inadequate continuing education for nurses in Nigeria. Also, I wish to apologize for some technicalities in my slide presentation. So I'll move straight forward. When we talk about continuing education, it has to do with learning, relearning, and unlearning. We learn, we relearn, and we unlearn. I was so happy when I learned that the organizers of this competition is called Dynamic Nurses, because we are in a dynamic world, a world that changes, and that is in line with what I'm talking about, the continuing education. So as nurses, we should try as much as possible to evolve, and be up to date. So why I'm obsessed with this topic, why I brought this topic to my essay, was what happened in our during our clinical posting at the University of Uyo Teaching Hospital. So we were to assist our matron for a wound cleanup. Yeah. So when we went there, we had an intern, a medical lab scientist, who was assigned to get a wound swab for analysis. So when she came, she told our matron they had a kind of polite argument that the correct the correct method for that, for getting a wound swab, was for the wound to be cleaned first with normal saline. But our matron insisted no, that's not the best way. That you have to get the swab first before you now go ahead to clean the wound. And because she was, of course, the elder there, we had to just accept it. But when I came back to the house, I started browsing, and I learned that actually what the medical lab scientist intern said was actually the right thing. That when we are getting a wound swab, we clean the wound first for uniformity, so that the result we get will be accurate. But just because our matron, I won't say she was wrong, because that was what she was taught. And like I said, we are evolving, so the knowledge now is also evolving. And for us to get the adequate evidence-based practice, we also have to evolve as the world changes. So as a result of that, I've structured a solution here, which I call CSEP. CSEP here means Structured In-Service Continuing Education Program. What does it do? It gives an avenue for nurses, still while in practice, to be taught, to be exposed to the new practices, to be exposed to the new techniques on doing things. Knowledge is dynamic, yes, like I said. So how is this supposed to come to play? Okay, we will get the NMCN and of course the NANS to um, provide a policy that all nurses, all the hospitals, and the nurses, of course, the directors of nursing services, they will implement a structured in-service continuing education once every month. All the wards in the hospital, all the wards, for example, in a teaching hospital, all the wards will provide a representative of that, or maybe their ward head in charge or whatever, or a representative anyhow, to come in and be taught on the new measures, on the new ways of doing things. You can be taught on wound management, you can be taught on prevention protocols, the best and the most modern ways of handling these things, early sepsis detection and things like that. And then when you are done, you now get back to your wards and share it with your fellow nurses, share it with your colleagues, teach them, and also develop a plan. Maybe you can include it even in the plan of care, include that this is what was taught for this month, and then you ensure that all the nurses there have been acquainted with that. That's for the CSEP. And then how do we get strict compliance? We will ensure that this is uniform that what is taught this particular month is taught in all the hospitals across Nigeria. That's why I say that NMCN and NANS will come in to play on this very well. And then at the end of every year, we always have an examination. Now, if you don't pass these exams, you will not be you not get your annual license renewal. So that everybody will take, all the nurses will be serious about this policy. So you take it, and then it can also be as a criteria towards promotion. It can also be as a criteria towards promotion. Now, aside from that, I've also come to note that most of our nurses are overworked. They can't even go out of service because of the work. So some of them have only 1 month leave, and that 1 month leave, they cannot go out to study. And even most of them, they don't have mobile phones. So also, each hospital should ensure that all the nurses there have access to phones that have internet services. Why would they do that? So that they can be able to also learn on their own to keep to the modern and updated ways of handling issues, of handling nursing practices. Now, people will say, okay, some nurses don't have money, some nurses they cannot afford this. Ensure that the hospitals, they deduct a little stipend from those nurses that don't have. They can keep it. By the end of a year, they will gather that and make sure that every nurse in Nigeria has access to a phone with internet services, that they can also improve themselves along with the CSEP protocol. Thank you very much.
Thank you for that presentation. Please, do you have any questions?
I have a question.
Okay, Ma, please go ahead.
Can we meet some people? We get
echo.
Okay. Thank you so much. That's I'm very passionate about continuing education, and I know that that's one of the major roadblocks to not just in Nigeria. Okay. Getting to the next step of efficiency. You've identified a very key issue, but what I have a little bit of question around is the implementation and the strategies for implementing that. Because these are two, from what you presented, I've seen two things here. One is the need for professional development via continuing education, but the other one is the accountability, which is the accountability that lies upon the individual nurses, because that's part of the competency for you to continue to practice, right? You have to meet the competency of accountability. So providing cell phones, while that's my son, okay, but I don't think is actually feasible, right? But what I can suggest, what I think might be, or I can ask you this instead of suggesting, and also every other person on the platform, because I think this very topic is something that impacts everyone. Okay. Do you think there's a better way of ensuring, or a better process of ensuring continuing education based on key competencies? And how I want us to think about it is because nursing, there are like subspecialties, subunits. People like you have midwives, have people that work in surgery, people that work in the theater. So what their needs are going to be tailored, right? I think it's going to be very, very cumbersome for the national body generally to manage this if they don't partition it per specialties. So do you think there's a better process to ensure adherence, okay, to this continuing competency? And how do you think we can leverage on the accountability piece for nurses while also holding the national body accountable? I think it's like a very multi-layered question, but let me know if you have understood.
I can contribute to that.
Okay.
Because you see, if you come to Nigeria, most of the clinical nurses, especially the the matrons, in quote, they think they have arrived, and they are not even ready to learn, unlearn, or relearn. So they feel what they know is right, and they don't want to. So I feel the only way they can implement this, the only thing they take serious is promotion. So the only way they can implement this is the same way the doctors, they don't write the normal promotion exam the nurses do. We write promotion like the same way the HCAs does, the same way the cleaners do, but that should be changed. If promotion exam can be tailored to your practice, to your specialty, it will look like a research. And every year that you're supposed to face a promotion exam, you bring up something that you have researched or something new that you have come up with. Let it be like a way for us to like research, give them a topic on what they are doing to research on, and let the exam be based on what they are practicing. That is the only way nurses can be serious. But when you say you want to provide them with phones and all that, they can use that phone for any other thing except for what it's meant for. So those ones are not feasible. The only thing most of the nurses take serious is their promotion exam. So let the promotion exam be tailored towards the nursing process, what is being done, how to improve nursing. Make them to research into things, and you will see that nursing will leave this stage of where we are, that people see us as lesser professionals, and let it be, instead of going back to school, let that phase come up, and you see people taking education and learning serious.
Thank you so much. Thank you so much, Alexis. For that.
Thank you, ma.
I will play your indulgence for 1 minute here. You know, this speaks very personally to me because I practiced as a pediatric nurse before coming up, but I didn't actually. I was a very young nurse in the pediatric ICU unit, and my matron, who has been there for I think 30 years, I don't know how long, but I will just quote 30 years because she says this all the time. So we had this baby that was being they were doing exchange blood transfusion. Do you guys know what that is? Do you guys know what exchange blood transfusion is? Nobody?
Do you know the medical name for exchanging blood?
Exchange blood transfusion is like, you know, when a baby has jaundice, right? It's very severe jaundice that they are at risk for connectivity because it can pass through the blood-brain barrier, right? And then it is going to cause irreparable damage to the baby, including death, right? So you have to remove all of those blood and then give the baby a blood. That's what they call exchange blood transfusion, and it carries high risk for infection because you are actually transfusing this baby over an extended period of time. You are removing their blood while giving them blood. It's like a double procedure at the same time, and it has to be done at the highest level of sterility. Okay. And so they brought this patient in, this baby in, and though I was a young nurse and I wasn't a pediatric nurse, but I had read, because I knew I was going to practice there, I went and bought the pediatric textbook, okay? The latest version. So I had read everything on that textbook, page to page. And my matron was a pediatric nurse who did pediatrics 100 years ago. I don't know when she did that, you know. So when they were doing this procedure, and I said, oh, this is not the right way to do this because of this is it. This woman actually slapped me.
Yeah. I was expecting that.
Yes. Yeah. She slapped me, but that didn't stop me. I continued to discuss with the consultant, and then it happened to be that what I was proposing was the right way. So when they went to the textbook, they saw that was the most recent recommendation on how to get things done, and that happened to change the practice for that very unit. But it came along a whole lot of consequences. So to the point of Alexis, what Alexis said in terms of tying it to promotion, because that's what nurses care about, and also to specialty specific, because this is not to be really honest, professional development is not a leisure. It's not something that you do if you can or if you do not, because patients' life right? Their prognosis depends on that. You can imagine if we continue to hold on to the things that we used to do in the past.
We knew.
You know, do you know how do you guys know how hand washing came about? I'm not going to go into that, but anyways, so these are things, and you as nurses, you as student nurses, you have a very big role, because you are the one, you are studying. Most of you are more current than those matrons. Okay, you are studying, you are using the most current textbooks. Trust in your research, trust in what you're learning, and be humble about educating them, even when they don't want it. Think about it, you are doing it for the patient and for your answer. What kind of nurse do you want to be? Do you want to be the nurse that conforms to what is outdated, or the nurse that brings reform? Okay. Thank you so much.
Thank you very much. Over to you, moderator.
Thank you very much, Ma. So the next speaker is Abdulmalik Sadia.
Is he here?
She's here. So
Are
you
you here? Are you here?
I'm here, ma.
Okay.
You have exactly 5 minutes. Thank you.
Yes, ma'am. Good day, nurses. Okay, I will start with a question. Can you raise your hand if you've ever been shouted at, ignored, or talked down to at work because of your rank? Am I sharing my screen? Again, we are called to heal others, but who healed us when bullying and rank silenced our voice? My name is Sapti Abdulrafi Bolashade. I'm a 400 level nursing student at the University of Ilorin. My essay is titled Bridging the Gap, Addressing Workplace Bullying and Hierarchical Bias in Nigerian Nursing Practice. Sorry, am I audible? Okay, thank you. The central argument is that beyond the well-known challenges of poor funding and inadequate equipment, Nigerian healthcare is facing a silent internal crisis, one rooted in how healthcare workers treat each other. I identified 2 major problems: toxic use of authority within the nursing hierarchy and bias based on tribal and religious differences. On the issue of hierarchy, the word environment often contradicts with what we are taught in nursing school. We are trained to ask questions, seek clarification, and practice safely. But in reality, asking a simple question can result in public humiliation or verbal abuse from a senior colleague. This creates a culture of fear over competence. Juniors and students especially stop asking and start guessing. And in clinical settings, guessing costs life. I illustrated this with a real medication error case. A friend of mine, a student nurse, was asked to administer 100 milligrams of tramadol intravenously. The ampoule was labeled 50 milligrams per 1 ml. This means that she needed 2 ml, but out of fear of being reprimanded for asking, she drew up 2 full ampoules and gave 200 milligrams instead. The patient survived, but the student was punished without anyone examining the toxic environment that caused our silence in the first place. This is the core of the problem. We punish people without fixing the system that broke them. On the issue of biasness, I discussed how tribal and religious affiliation shape workplace relationships in ways that are deeply unprofessional. In many words, favor is given to juniors who share a senior's language of faith, while others face exclusion, mockery, and bullying. I noted this is particularly visible in some parts of southwest, south and southwest. When a nurse feels like an outsider because of their background, their confidence drops and their performance suffers and teamwork collapses entirely. To address these problems, I propose 3 practical nurse-led solutions. The first one is empowering nurse managers to shift from a punishment-based approach to a just culture model. A just culture model is one where errors are investigated systemically, not just blamed on individual at the bottom. The second solution is introducing periodic psychological evaluations for nurses to address burnout and unconscious bias. Since many bullies in the workplace are themselves struggling with nurses themselves struggling with untreated mental strain. The third solution is establishing a zero tolerance policy for bullying up by an anonymous reporting system connected to bodies like NAM and NOSA so that juniors have a safe channel to report abuse without fear of criticism. In conclusion, I argue that the interpersonal culture of the world is just as critical to patient safety as any clinical skill. We cannot deliver holistic, quality care in an environment built on fear, favoritism, and intimidation. Bridging the gap between senior and junior, between ethnic and religious groups is not just a professional responsibility. Thank you.
Thank you so much, Ma, for that beautiful presentation. Something that we continue to face in this part of the world. But yeah, any questions or contributions?
I have a contribution. This
Okay, Ma.
this particular topic is very dear to me because that is what I stand for. I'm one of those nurses that stand against bullying junior nurses. And when interns come to me or come to any facility where I work, I stand for them. Because one thing I have noticed with bullying is it reduces self-esteem. It makes you doubt your capabilities, and it also makes you commit more errors than you would have committed if you are able to speak up. Okay, so one thing I would advise every nurse here is, if there is one thing you should have, is confidence in yourself. If you know what you're talking about, don't allow anyone talk you down on it. And when you're when you're giving out your suggestions, do it in a humble way. Because some people come up to you like, yeah, I'm a student nurse, I'm from the university, who are you? Like, I know it's the... So when you approach the senior nurses that way, then what you should expect back. So the thing is, you can't rule out bullying. It will continue, but we have to, how to minimize it is the problem. And how do we minimize it? There is no stringent rule that will stop bullying anywhere. Okay, especially when it comes to senior nurses and junior nurses, or student nurses and the practicing nurses, no. But you have to come up with a strategy yourself. First, know who you are, know yourself, know your words, know what you are coming with into the practice. And when you're dishing out these things, when I came in as a student nurse, earlier when I started my practice, that was in 2009. I think I had bullies, but one thing that stood out for me was when I talk, I don't even talk to nurses, the senior nurses. When the doctors come for their rounds, when I speak, they know that the nurse is speaking. Most times they say, that one is a doctor. No, I tell them I am a nurse. So always learn to say your points. And at that point, the matrons had no right to talk me down, because the only thing is they do the side talking, nurses. So, but coming to me to say it to my face that no, they don't, because I know what I was coming for. Every time I'm going for my practical, I read, I study every patient I had the previous day, and I come up with suggestions. You can't come for a round. I am not those nurses that carry gallipots or carry trolley for doctors. No. When you see me stand as a nurse, you don't even tell me, though. There are things, see, presentation matters. So as student nurses that are going out there to practice, one thing you should imbibe this personal confidence in yourself. That is not arrogance. People mistake confidence with arrogance. It is not arrogance, but no, even in that your confidence, know your worth, know what you're coming for. Not when they ask you questions, you are blabbering. No. If you know exactly what you're bringing to the table, people respect you. Nobody bullies the brain. Nobody bullies what you know, what you are bringing. People might be intimidated. You can't stop that. But at the end of the day, what you know is what you know. And when you're bringing it to the table, bring it with humility. And we can all work together to stop this bullying. And how do we do it? Learn to support your nurses. That is what we keep telling the senior nurses. Learn to support these nurses that are coming, because it is the same way you put these nurses out there. You see how the doctors protect their own. Let us learn to protect our own. Let us learn to project them, not as worse or not as not knowing what they are doing, but as the best brains that are coming into the system. It is how you present the junior nurses that these doctors look at you, also the senior nurses, but they don't even know that. So bullying will continue, but learn to come to the table with evidence, with confidence, with what you know, something that is worth it, that not just the nurses will see it, but every other healthcare professionals will see you and identify that you are a different person. Thank you very much.
Thank you so much.
Thank you so much, Ma, for that passionate, very insightful talk. I'm pretty sure you spoke to me as much as you spoke to every other person. The next speaker would be Dunini Alashe. I'm very sorry again if I'm not pronouncing your name very well. Some of the names are spelled wrongly here. I don't know if you're on the call. Okay.
Okay, hello, good evening. I'm on the call.
So you have just 5 minutes. Exactly 5 minutes. Thank you.
Thank you very much. Please, I would love to, standing on the existing protocol, please respectfully, I humbly seek that everyone mute their mic while I present my essay. Please, can we all see my screen? Okay, so I'll just start. As the Nigerian health system advances, the condition of nursing appears to be deteriorating. Nurses occupy a very special place in the healthcare system, and we are in charge of the bedside day and night, observing patients, responding to changes, offering comfort, and coordinating care. We are often the first to even identify when the patient needs immediate fluid replacement, antibiotics, or pain relief through IV access. And we are the first to even detect when there's infiltration, or what the layman would say, when the line is tissued. In many clinical settings, even when a nurse is fully trained and capable, that nurse is still expected to wait for a doctor. And in many hospitals in Nigeria, and most especially the hospitals that I've worked in for my clinical postings and also volunteered in, both in Ado-Ekiti and in Lagos State, the skill is still wrongly treated as the role of a medical doctor, even when nurses are very, very good at fixing these things. In fact, I've been in a situation whereby a doctor is told to fix the IV line, and then just find it very difficult to do. And along the line, few doctors who are humble will reach out to the nurse to fix it. And just on one trial, the nurse is able to fix this thing. Believe me when I say this is not a way to undermine or badmouth our great physicians. It is just the reality of things, and these are like the problems that we go through in the clinical setting. And these situations create delay, frustration, and even sometimes preventable harm to the patient. In critical care, emergency units, and even on routine wards, a delay of just few minutes can lead to a patient being in pain and even distress. And this is what sometimes even leads to the whole idea of people saying nurses are wicked, or they just look and decide not to act when their patients or when their family members are in pain. And the effect goes beyond treatment alone, because the family watching that delay may wrongly assume that the nurse is careless or unqualified, even when in reality the nurse is bound by an outdated system. And the problem even goes beyond procedure. It reflects a deeper issue of professional undervaluation. Over time, nurses has been too streamlined into roles seen as supportive rather than autonomous. And that weakens identity, confidence, and even morale. For example, me, as a male registered 400 level nurse in Afebawala University at Ekiti, I just feel like I can do more, better than assisting the doing ward rounds, or maybe general management of the patient. I can do more. Why can't I fix IV cannula? Why can't I practice in much more professional settings? And like, it just undermines and just weakens upcoming nurses. And my solution to this problem is a realistic and nurse-led solution to, for example, now strengthen the nurse administration. And also, we can also look at nursing beyond the bedside. Some of us want to be nursing administrators, and these are the only type of people that can correct these errors, because it has become a thing in most hospitals in Nigeria. And if you are not in a place where these rules are being made, I feel like there is no way in which you can change these policies. And this is not a way to replace doctors, but it will allow each professionals to function according to training and responsibilities, from nurses acting promptly on procedures that they are qualified to perform. And it just bridges the gap, and it corrects the problem of people tagging nurses as wicked people. And also, we can also have training programs for our nurses on how to fix cannulas. And for example, now, as a 400 level registered nurse who became registered this month in May, we've been going doing the training, and our clinical postings. We were exposed to fixing IV cannulas, and I mean, it's a very, very interesting procedure, and we should not be restricted in the place of aids, and also showing superiority in the clinical setting. Thank you very much. And I'm so sorry, I forgot to introduce myself. My name is Dominino Alashe from Afebala University. I'm the founder level registered nurse, and thank you so much for listening to me. Thank you.
Thank you so much for that presentation. That was a very nice presentation. Is the moderator still here? Okay, does anyone have any question for Alasa? Any question, any contributions?
I want to say thank you so much for that. He did
go ahead.
He did very, very well. Thank you so much for that. And then I like the line where he said that nurses can actually be nurse administrators, and that is where I love the most, because we are not studying all of this to just end up by the bedside, right?
Sure.
Just that. So thank you so much for that.
Okay. Who else do we have left here to present? Is there anyone on the line that I've not been able to present? Favor. Cedric Favor.
Yes, ma, I've not.
Yeah. Go ahead.
Okay, good evening, everyone. So I'll be sharing my screen now. I'm coming. Please, can you all see my screen?
You can go ahead.
Okay. 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 So, thank you very much for the. Can you all hear me, please? Please, can you all hear me?
Go ahead, yeah.
Please, can you all hear me? Okay, okay. Thank you. Okay. Thank you so much for this opportunity. Listen up, nurse. When it comes to hierarchy, I can order you around. You can't. Is that clear? I earn 250K while you earn 80K. Is that clear? You report back to the doctor or to me why I don't. Is that clear? You get to clean up the patient's mess and I get to work with machines. Is that clear? Now hold on to the waiting room for the next instructions from the doctor or from me. This was the exact word of an intern radiographer sometimes earlier this year. And I don't know what I felt, whether it was disgust and irritation. And in my mind, I was like, is it only nurses that are being taught ethics, or is it only nurses that are being taught multidisciplinary collaboration? Good evening, everyone. Thank you so much for this initiative. And on this, my name is Sadiq Favor, and on this Nurses Week 2026 essay, I'll be presenting on LD competition among healthcare workers. So the problem, what is this problem? The healthcare system in Nigeria has actually shifted from its true goal, which is working collaboratively, every member of the health sector working collaboratively to improve the health of a patient. Instead, we now have an hierarchy, a torso of who is better than who. This plays out interprofessionally, doctors, radiographers, and other doctors, radiographers, medical lab scientists, and other health professionals. They view nurses as inferior. And even intraprofessionally, within nurses, there is a rift between School of Nursing graduates, nurses from School of Nursing, and nurses from the university. There is a tussle of who earns better, who knows practical more. And the worst of it all is that even the patients and their relatives now sense this thing. What is the root cause of this unhealthy competition among healthcare workers? First of all, we have historical paternalism, in which the current healthcare system in Nigeria is still rooted under the mindset that only females should do nursing, because back in the days, nursing are well dominated by female, while medicine are well dominated by men. So this mindset was never dismantled. It still carried on into this process. I've seen videos whereby they ask students, what course are you studying? They say engineering, they say agri, but immediately a guy mentioned nurses, they put a Cinderella hat on the guy. So you even hear people say, man, they study nursing, all this kind of thing. So this mindset is still there, and we know that Nigeria itself is a patriarchal system. So because the nursing profession is female dominated, they give us that inferior role and subservient role that we are meant to just run errands. Then we also have policy gaps. The governing council in Nigeria is not even helping matters. We don't have anybody in the governing head body to actually convey our pain to the government. All this interprofessional bullying is just as if it's only the nurses that agitate for it, and nothing happens afterward. Then we have fragmented identity. Just like I said, that there is a tussle between graduates and nurses from this College of Nursing and the one from the university. There's often this thing of rift of who is better, who knows practical the more, who suffers the more, and this has led to this has led to high nurses patient ratio, and numbers don't lie. The Nigerian nurses to patient ratio is 1:1,160, in contradiction to World Health Organization, on which is 1:5. So in Nigeria, we see a single nurse we attend to over 10 to patients. Over 10 to 20 patients. So it makes them overburdened. A lot of nurses say they don't even want to work in Nigeria because they will tell you that they don't respect them. I've seen a particular doctor told me that he had to go back to school to study medicine because of the way they look down on the profession. So my proposed nurse-led solution, we have clinical validation. On this clinical validation, nurses must own the nursing process through ADPI, assessment, diagnosis, planning, implementation, and evaluation. If we look at diagnosis, medical diagnosis only take one part. Radiographers, they take only one part of diagnosis. But we nurses, we take the whole part of diagnosis, psychological, emotional, and everything. We take care of all the whole nursing continuum. Secondly, we have multi-professional education. Nurses should lead clinical forums, there is case discussion, prove to every professional that we are intellectuals and not just errand runners. Third, we have nurses-led research. I think earlier this year or last year, there was a collaboration with Otitology in the US with Enunsa. They taught us on how to carry out research, and we know that data don't lie. So when we back up our practice with research, there is going to be this confidence. Four, we have harmonious pathway. There should be a unified pathway, whether okay, the government should say it is College of Nursing and it should be university. This is the pathway that can graduate nurses in Nigeria. Auxiliary nurses should be wiped out. In a system that wants quality, there should not even be anything like auxiliary nurses. Then 5, policy lobbying. Now must advocate for zero tolerance against bullying. As individual nurses, we can only do little, but we can also in our own way act, sign petition, write position, mobilize through union. Change begins with those willing to demand it. So ultimately, I feel like everything lies in our hand. There should be a shift in professional identity when we see ourselves as advocates, the pillar with which other health professionals can function. We create when we are not in the system, there's a vacuum that cannot be filled. Other health professionals, they are going to notice it and they'll begin to see us like that. After all, people see you the way you perceive yourself. Thank you.
Thank you very much for that presentation. I think my name is. Please, do we have any questions? If you have any questions, please raise your hand.
I have something to say.
Okay.
Hello, can you hear me?
Yes, please
Go ahead.
Okay. So thank you very much. My name is Uchi. There's something that she said that really struck something within me. It just reminded me of the fact that there was a question I asked, especially when I was still running into politics and all of this stuff. I asked myself, why is it that medicine students are always together? Why is it that they know how to plan themselves and, before coming out, before presenting themselves to the world, as they have already made a decision within themselves, so they stand together? Why is that nurses? Why do we always do things separately? Why are we always fighting within ourselves? And there was something else that made me solidify that question that I was asking myself. And this is it. There's this thing going on TikTok where you'll be seeing, they'll be like, nursing students, they are saying something, have you read? Or no, it's like this. They are in a class with nursing students and then they'll put snake face. I don't know if you guys have seen something like that. Please indicate if you have seen something like that. Like they'll put a snake face on the students. And basically what that video, that short clip is trying to say is that we see ourselves as snakes. We cannot be trusted. We can't trust each other. So I feel like this is something that we should really work on. And like this particular essay, like this last person spoke about, really hit that question that I've been asking myself. So I just said, let me bring it up. And if you guys still have any more contributions or answers to the question that I've been asking myself, I really appreciate it. Yes. Thank you.
Thank you, Uche. I'm going to answer that. Thank you, Uche. Thank you so much. So, in medicine, they take an oath, okay, to mentor. They take an oath of mentorship, and an oath, and mentorship is different from teaching. So in teaching, whether the person understands it or not, that is up to them. But in mentorship, you take the person as your personal responsibility. Okay, so when you're wearing the cap of a mentor, you are ensuring that the person do not just understand or grasp the theoretical concept or the practical concept, but they equally embody the behavioral aspect that enables them to succeed at their own pace. That is, you're more of a protector. Okay, so that is what the difference is. They take the aristocratic oath, which is the oath of mentorship and support, to be able to make sure that the person under them actually is able to practice it efficiently, and that ensures that they are protected. So if anything happens in medicine, before it comes out, they will make sure that they've tried to sort it out internally before bringing it outside. But nurses is the opposite.
Okay, do you think we have that mentorship plan in nursing?
I to be really honest, that's actually that's actually why I started the association, because and that's why we've been able to make progress. We have people, and the mentorship takes the power away from the center, right, and brings it to individuals, right? So what it does is it empowers individuals, and then from individuals it kind of goes out to the periphery, which is the stronger way of doing things as opposed to the other way. I think that's what you and I, especially this younger generation, because we are seeing firsthand the impact of this terrible thing, and where it has landed us. We should take it up and ensure that we reinforce it. And I don't know how it is in Nigeria currently, but I think especially for minority nurses, the only reason why we're able to get to where we get to now is because of mentorship, even though it is not efficient as it should be, but it's a work in progress. And seriously, that is the only way out for us.
Yeah. Okay. Thank you very much. If I'm going to contribute to this, but first of all, I want to ask a question for everyone that is here as a student nurse. How many of you have a mentor? Who do you look up to? Because it matters a lot. So many people we don't even have mentorship in Nigeria, but you as a nurse, personally, you should have somebody you look up to. You should have somebody you learn from, because you embody what you see. You act like the person that mentors you. Who is mentoring you? Is it that timid matron, or is it somebody that does not even want you to grow? Who is your mentor? Your mentor matters a lot. And you should be looking out for people that are good in the profession that you can attach yourself to, for them to mentor you. But your healthy professional, I've forgotten the topic she just presented. So the unhealthy competition among professionals, it won't stop, especially with nurses, because we have a majority of females. And the truth is, there is nobody that wants you to surpass them. So when they see student nurses most times as a threat, because they feel you're coming in to surpass them. But if we have that mentorship mindset, a mentor sees you as somebody that, I want this person to outgrow me. I want this person to do more than me. That is how a mentor sees you, and that is what we have in medicine. But in nursing, rather than them seeing you as somebody that, okay, I want these people to come up and represent this nursing profession and take it forward, rather they want you to be down so that you cannot climb. So some of them will tell you, so now because you think you are from the university, you want to climb on my head. No. And people don't even know that it's how you position yourself that people look up to you. These students that are coming in, it's how you position yourself that they also look up to you. They call themselves Gen Z. When they come into they don't take trash anymore. It's not like then that you just deal with student nurses but now when you deal with student nurses, you see yourself all over social media. But that's not to say that as a student nurse, my advice is, as you're planning to go into the clinical system, plan to make a change. There are so many things we can change. If you're depending on NAM, you're depending on the Nursing and Midwifery Council, I am very sorry to say that you will not see change. Change begins with us. Change begins with you. Change your mindsets. Change the way you look at every other nurse out there. Believe in yourself. Believe in other nurses. Don't see your fellow nurses as competitors. No. What are you competing for? We are all in this to boost this profession. So don't see them as competitors. When they come in, you feel that you don't feel less of yourself, first of all, because it is how you see yourself that you see others. If you see the student nurses coming in and say just imagine somebody that have been in a clinical setting for 30 years, somebody that is just coming in becomes your competitor. That is to show the mindset of the people that are in the clinicals. That is to show the thinking, how low some nurses think of themselves, that they even see doctors as their lords. So when you're coming into the practice as a student nurse, I have given you not just one, not just two. There are so many things. Come with your strategies. Come prepared. Cooperate with every other nurse that you see. Don't compete. You are not in a competition. We are all there to collaborate together and make things work. How we see ourselves is how patients see us. And that is why you see that the bullying from the other professionals or from, have you ever heard a nurse bullying a doctor or a nurse slapping a doctor? But you see that most of the time that doctors, they raise their hands to the nurses and slap the nurses. But anyway, for me, we'll be tied that person anyway. So that is by the way. So you put yourself in a position where nobody embarrasses you, where nobody sees you as less than who you are. Thank you.
Thank you very much, Ma, for that contribution. So that was the last speaker. Somebody, okay,
Sure,
you
Ma,
can
go
go
ahead.
on.
Yeah, I initially wanted to, say something about mentorship, but you've actually done justice to that. But just to encourage us, honestly, I always refer myself to as somebody who have gotten to the point where I am and the point I think I will still get to because of mentorship. So just to encourage us, students on this call, do not give up on yourself and try as much as you can to just have that person. It might not necessarily be one person, but try as much as you can to just have that one person who believes in you and who believes in, the vision you have even as a student nurse right now. Mentorship has really made a huge difference for me, and it's something that I always encourage. And again, I just want to appreciate the last presenter, Favor. Favor, your slide was really excellent. I must commend you for your slides. Well done.
Thank you very much, Nurse Chioma. So, on behalf of non-star national body,
No, I think we had one more person who raised her hand earlier when Favor. Yeah.
okay, yes, Nurse Blessing, please ask your question or make your contribution.
Good evening, everyone. I've not presented.
Oh, you were absent?
Yeah, she's here to present.
Okay, please, you have exactly 5 minutes for your presentation, your conclusion, everything should be in that 5 minutes. By 8:41, you should have finished your presentation. Thank you.
Good evening, everyone. My name is One Blessing Kilichi, and I'm a 500 level student of Abia State University. I'll be bridging the information gap on nursing-led patient education in Nigerian healthcare system. I'll be sharing my slide. Please just kindly indicate if you can see my slide. Okay, before I start, I would love to carry everyone along, and I will begin with my personal story of what happened to a close relative, specifically my father. I'll ask a question before I begin my story. What does it mean to treat a patient's body? What does it mean to treat a patient's body while abandoning their dignity? The day my father collapsed without warning, I learned that a hospital can save a life and still leave a patient and their family shattered. Not through negligence, but through silence. That fateful day, my father left home very healthy that morning. But by afternoon, we got a call from the hospital in the emergency ward that my father had fainted. We went to the hospital. We stood helpless for a moment. We watched procedures we could not name. We watched procedures going on we could not name, being performed for reasons like we could not even explain. So my mom summoned courage to ask a nurse, what is actually going on? The response was very unpleasant. Madam, move. Can't you see we're working on your husband? Don't you know his blood sugar is very high and he's diabetic? Diabetic?
that was like, it was like a life sentence, a verdict with no explanation. My dad was discharged few days after. His diagnosis, he was discharged with a diagnosis he barely even understood, neither did we. No dietary counseling, no guidance. In desperation, we turned to Google search engine for his diagnosis and neighborhood for hearsay. This is my family story, a harsh reality experienced in Nigeria. Poor patient communication is a nationwide crisis. Patients across Nigeria routinely receive medication and diagnosis with no adequate explanation, leaving families more confused than they arrived to the hospital. Patients who do not even understand their illnesses frequently stop treatment, seek harmful alternatives, or end up relapsing into their illnesses. Why does this keep happening? 1. Severe understaffing. In Nigeria, public hospitals suffer from insufficient nurses. Severe understaffing. In Nigerian public hospitals, there are insufficient nurses to meet patient demands. Nurses are forced to prioritize immediate clinical tasks over patient education. This thereby limits patient understanding of their health conditions and treatment plan. Number 2, language barrier. Nigeria has over 500 languages. Although English is Nigerian lingua franca, many patients are more comfortable communicating in their local languages, which have created a challenge for effective nurse-led patient education. Research from Nigerian hospital confirms that this crisis, that poor nurse-patient communication directly reduces patient satisfaction, treatment compliance, and safety outcome. I take my mind back during a clinical posting. I remember
Please, you should be rounding up now, Blessing. Thank you.
Repeatedly refused medication, not out of defiance, but out of fear and confusion. But a nursing colleague of mine decided to explain the drug mechanism of action and purposes. So I'll be presenting 3 practical strategies. 1, a shift-based bedside education. A 5 minutes per patient can change everything to educate the patient diseases, diagnosis, treatment plan, clarifying the treatment to see if the patient understood or is well communicated, teaching the patient to identify warning signs. Number 2, a teach back method at discharge. As nurses, we should never assume, but we should confirm. Before every patient is discharged, the nurse should educate the patient first and ask the patient to repeat those key informations, thereby making the nurse to know if the patient have understood the education. Number 3,
You should be
a local
concluding now,
material.
Blessing. Thank you.
Thank you.
You can just say your conclusion.
Thank you, ma. Okay. Number 3, a local language and material. For many Nigerians, comprehension begins only when healthcare information is delivered in their local languages. So I suggest that illustration leaflets in their indigenous languages, word information board, audio health messages in their indigenous languages. Nurses are Nigerian frontline educators, whether we like it or not. We are always present with the patients. Our voices always heard because we are advocates, and also education is care. We need to know that saving a life is not enough. We should help them to understand the life being saved. No Nigerian family should stand outside a hospital ward in helpless confusion like my family did. No patient should leave carrying a diagnosis without them understanding. A patient is meant to be educated to restore their dignity and rebuild, and this should be done to rebuild trust in Nigerian healthcare. Thank you very much.
Thank you so much. Okay. I think that's all we have for the presenters, right? Do we have anybody that have
No,
not
we
presented?
have
I don't.
Damisola and Elijah.
Damisola was unable to present the first time, right?
Yeah, even the second time our network was still disturbing. She was on the
so
call, but she
who
has
is there
left
now?
now. Elijah.
Okay. So
Elijah Abraham.
Elisha wasn't there when we called, right?
Yeah, it was not
The first time.
available.
Okay.
Yeah.
Okay. So
Please,
let
Elisha, you
Damisola
have.
present if she's available.
She's not available, ma. She was on the call
Okay.
before, but
So
she's no longer on the call.
okay. So we just have Elisha, right?
Yes.
Okay. Elisha, go ahead.
All right. Okay. Good evening,
Elisha, are you
everyone.
ready
Good
for us?
evening.
Go ahead.
Yes, I am. Good evening, everyone. Good evening, nurses. Good evening, student nurses. My name is Abraham Elisha, a 400-level student from the University of Ilorin. So yes, I will share my screen now. Can we see my screen?
Yes, we can.
Yes.
All right. Yes. So when I heard of the topic bridging the gap, I thought about which problem can we have a solution for, that is the solution is already available, is just to implement it, a solution that can be readily implemented, that requires little to no effort from even our part, that already has an established framework. And I came up with although it has already been in use in clinical setting, but I want to bring to us one of my experiences in clinical postings. I discovered that most times, I think it's due to the nurse-patient ratio and the workload and the tiredness. I noticed that when it's time for handing over or shift change, most times they don't properly explain the condition of the patient to the incoming nurse or the next person they are handing over to. And while I can understand that the workload, maybe due to the job, the migration of nurses and everything cannot be readily changed, I want to bring to our attention a framework that has already been in existence, that is just to implement it during that work shift change, and that is the SBAR approach. And the SBAR approach stands for situation, background, assessments, and recommendation. Now, we've already established the fact that there is a very low nurse-patient ratio in Nigeria. In fact, you can see that for every nurse, there are about four. Like the current ratio now is, for every nurse, there are about 4 patients. Meanwhile, there are 1.4 nurses per 1,000 people. Meanwhile, the recommended minimum is 4 nurses, is 1 nurse to 4 patients. So we can see that in Nigeria is not really applicable, in the sense that there are mass migration, and the staff pool in Nigeria keeps reducing instead of increasing, even if we still have people graduating. So now, this causes a noticeable problem, in that due to the high workload, we find out that towards the end of the shift, nurses get tired, nurses get exhausted, and sometimes they start skipping like some details of patients, especially during the time like during the time they are supposed to hand over. Some details around that time, they might skip it, and it's actually a human error, which is, can I say, it's not the blame isn't necessarily on the nurse now, but bring in approach that can actually address that, so that even if they are tired at the end of their shift, they can still cover the baseline of every single patient during the handover. So yes, as I said before, SBAR, the situation, the background, the assessment, and the recommendation. What does situation stand for? It describes what is happening right now with this patient. The background shows the relevant history, the medications, and the clinical context. The assessment, it shows the nurse clinical picture, what they believe is happening, and then the recommendation is what needs to happen in the next shift. So this now, most time when currently the times where I see this applied is only during emergency. Is when I was in A&E, accident and emergency, they apply this a lot. In maybe calling a physician, in just letting the next person know about this patient, about what this patient is going through currently. But I want it to be applied even in shift changes too, because I feel it's very important that nurses, even if they are tired, even if they are burned out, they should still properly cover the bases. So having this in mind, having this explaining the situation, going to the background, it gives a very concise picture of what the patient is going through without the nurse necessarily racking ahead, maybe telling stories, spending a lot of time without covering all her bases. So now, the safety hurdle. This SBA, it works in under 5 minutes. It shows which patients are most unstable, which equipment is failing or unavailable, and which tasks cannot wait past the next 2 hours. So now, the SBA template now handles the patient. It shows the pre-printed word-specific templates and that the outgoing nurse documents all the clinical info, and then the incoming nurse reads it. There will be no reconstruction. There will be no storytelling. There will be no trying to rack an already exhausted mind. So now, what will this model do? This model will now, if implemented in every shift changes, it will protect the patient against the highest risk moments of care. It will even give junior nurses a safety net in complex cases. It will create a clinical record that protects nurses legally, because it will ensure that every nurse, even if you are tired, even if you are burned out, although legally it's not an excuse, but SBAR framework will ensure that every nurse covers his or her bases, and it will also protect them legally. And it will also standardize quality. It will standardize care quality independent of staff experience. And if implemented today, it can be implemented. In fact, right now, there won't need to be any budget. There's no need for any approval. It can be implemented immediately because the framework is already there. It is already used by emergency nurses. It's already used in the hospital. What we are looking at now is to make it more common even in shift changes. But even when we implement this, there are some things that it cannot change, which is it cannot fix we know that it cannot fix the staffing crisis.
Now, please. Thank you.
Okay. Thank you. So
I said you should round up.
Oh, okay. Sorry. Thank you. So, like I said before, if in a system where nurses are asked to do the impossible every day, a 5-minute fix that protects their patients and shields them from liability is not a small thing. It's a kind of bridge you build while still waiting for the bigger one. It means that while still waiting for policy changes, while still waiting for things to get better, with our work environment, with maybe the pay and everything, this is something we can do now. It's cost zero. There is zero cost involved. There's no budget required. It's an immediate action that can be implemented today, and it's also evidence-based. There have been research on it. The framework is already available down. It's only on our part to implement it in every single shift change. Thank you.
Thank you very much for that very outstanding presentation. Thank you. Do we have any question from the participants or from the nurses in the house? or the guest? Anybody has a question for Elisha?
Yeah, hi. Good evening. Please, I want to make a contribution.
Okay.
Good evening, everyone. I'm Immaculate Obiche. So I just want to say a little contribution on what Elisha said, and also little from Blessing, what Blessing said. So on his approach, I also want to say that yes, the work can be tiring and it can be exhausting, and most of the time it's frustrating, but at least giving a patient information on maybe a question asked can also boost our knowledge, because it will help us to always get prepared that okay, this patient or patient A or patient B is going to ask me a question when I come. Okay, why am I giving him this medication? How is he going to help him or herself to manage his condition? And also it will also help us on our own side, because us giving a good information to the patient, it will help a patient to have a good relation with us. Maybe if the patient is feeling somehow, we'll be like, okay, nurse, after giving me that medication yesterday, see how I was feeling. And it also help us to lessen our workload, because it will help the patient to know how to manage his condition instead of coming to the hospital severally and piling up the workload. So us talking to the patient and giving them talks, yes, despite the workload, at least a 5 minute or a 2 minutes will not be much. We talk to them and like assist them on how to manage their health condition. And coming to on Elisha part on the assessment and diagnosis, most of this because of the workload, we do skip the nursing process just in order to cover the patient and cover the workload we have. But at least going through this nursing process will help us to achieve a good nursing care plan, to achieve a good to achieve a good goal during our evaluation, instead of coming over again to start a new nursing care plan in order to achieve a goal. So going through the diagnosis, the assessment and everything will help us know, okay, how has this person disease started and everything, and help us to achieve a good point to help in treatment. Thank you.
I have a
Thank you.
contribution. Uh, the, I want to say thank you to the presenter. I want to say three things. First of all, you are accountable for all your actions. You should know that. For every patient you're taking care of, at that point in time, you are accountable for that patient. And also, discipline comes into play when it comes to taking over and handing over. Another thing is over familiarity with nurses. Okay, so I'm going to buttress on this once. First, you are accountable for your nurse, your patients. When you're handing over, it is your responsibility to pass on properly to the next nurse what you have done and what is left to be done. It is your responsibility. If you see that as a responsibility, no matter how busy you are, and not until we start practicing it in Nigeria, when we come over to any other country, it becomes an issue. Most of our nurses have gotten into trouble because of this documentation and proper handing over, because we did it haphazardly back home. We think that coming over here we can do it that same way. No, the thing is, no matter the number of patients you have, you must have time to document on those patients, and you must have time to pass on that information to the next nurse that is coming. I remember while I practiced back home, sometimes you see nurses leaving their duty post and calling the next person, I'm leaving. So when you come, this, that is how they hand over. That is over familiarity. But here you can't do something like that. You must document and you must do a proper handing over. And there is nothing like over familiarity. When it comes to discipline is just you. Okay, I mustn't do this because this goes against whatever I believe. So your conscience comes into play when it comes to this. Have I been able to satisfactorily carry out my duty? Have I been able to do what I'm supposed to do for this patient? Have I communicated appropriately to the next person? Can this person carry on from where I stopped? So it takes a whole lot to be able to give a proper handover. And above all, be disciplined and be self-conscious that I must do this. If you continue to do that, when you go out there to other countries, it will not be difficult for you to continue with. Thank you.
Thank you very much, Ma, for that contribution. Please, if you are a speaker or participant and you've not presented, please use the hand icon and raise your hand. Is Damisola Ajayi here? Okay. So that means that all presenters have presented.
Yeah. So
Okay.
judging from what we have, how many people were able to present today?
I think 12.
12,
Because
yeah.
we didn't have. Okay. So from first of all, I want to thank every participant and guest, our judges, for their time. This is roughly 3 hours that we spent on this call. Thank you so much for your time, for your patience, for your contributions, your questions. I have learned a lot, and I think every other person on this call has obviously gained one or two powerful insights that will be included or embedded in their practice moving forward. Special thanks to NONSA National President Valentine Madu for collaborating with the Dynamic Nurse Initiative sponsored by or heavily sponsored by Nurse Alexis. We are very grateful. And for having the president of Nigerian Canadian Nurses Association in our midst, it is an honor. And the other judges too, we are very, very grateful that you gave out time to be here, to be involved, to listen, to contribute, and see how we are faring or how we're doing, our ideas, our thoughts. We say thank you. So the results will be called on the call. Ma, are you ready?
Can I say something? If that's okay?
No, not yet.
Yes.
Yeah, go
yes,
ahead.
please.
Okay, thank you so very much. Thank you everyone for staying. I'm really, really impressed that everyone stayed till 3 hours plus. And I'm so much impressed with the depth of work you all have put into this presentation, your research, your passion, and most importantly, the authenticity of the recommendation. Okay, I've learned so much myself. It is just like you guys took me all the way back to Nigeria, and I was able to. In fact, I traveled through different specialties, through different hospitals. Thank you so much for that eye opener and for awakening my consciousness of the seriousness of the issues that we still have, which oftentimes we do forget once you move out and you stay here over a long time. Thank you so much for bringing that awareness and for really, really, really taking this seriously. And if I can add one very important thing that is really close to my heart, please don't just take this as a presentation or as a competition, because what you get to identify the real issues, okay? Take it as something that you can we all need to work on and find collective effective way of changing these things. And to support this, I can't just come here and just watch. And this is really I'm so impressed. I'm going to give something to I know you guys have Alexis, you have like first, second, and third. Is that how it is?
We took it up to first 5 so that at least let's have the first 5. We have something for the first 5, yeah.
Okay. I'm going to support the last 5. Like, so just make it just so I'm going to give them something, just the last 5, just so that they can pay for their data. So thank you so very much. I am going to keep in touch with you guys. We're going to do more of this and even expand it more and more. Thank you so much. God bless you. Remember, there's no you without God. I don't know what you're doing. I don't know where you are, but just remember, if you're going to be a great nurse, because you're working with a healer, right? You need to tap into the source of the person that heals. That's how you actually make real life impact. Thank you.
Thank you so
Thank you very
much.
much,
Thank you.
Ma.
It was an honor having you, Bitch.
Thank you so much, ma.
Thank you.
So yeah, we have so the first 5 we have something for you, and the next 5 we also have something for you, and that's sponsored by the Canadian Nurses Association president. So thank you so much. We'll get back to you in 5 to 10 minutes time. So you just give us time to come up with something. Is the NOSA president still here?
Active and ready, ma.
Okay, so I want us to have a brief discussion in the next 5 minutes and come up with our first 5. It will be very nice to have our first, second, third, fourth, and fifth position. And it is an honor to be able to have this caliber of student nurses present today. I think this is one of the best presentations that I've had, like since I started assisting nurses, clinical nurses. I think this is one of the best, superb. Like, I don't even know how to just clap for yourself if you have participated in this competition, because you are the best. You did very well. And like I said, you also have every opportunity to come up in my game to also showcase your talents. Thank you very much. And I would say I love and appreciate you all for participating in the Dynamic Nurses Skills Initiative. This is not the end of our collaboration. We will do much more and make nursing in Nigeria better than what it is now. If we can all have this mindset, if we can all work together, I think it is doable. It is something that we can actually do. We can bring the change to Nigerian nurses, but it's difficult. But we can do that together. We stand, but we need to start with ourselves to bring up a change. Thank you so much. I am super proud of you all for participating. Over to you, Madhu.
Okay, thank you very much, everyone. First and foremost, on behalf of the NONSA national body, I would first and foremost love to appreciate our capacity mama in person of Nurse Alexis for first this initiative and all, for giving we the student nurses a voice and giving us the opportunity for us to be able to interact and come up with real life problems and also provide solutions to them. This has actually helped in shaping our minds and letting us know that, oh, we actually have should I say we actually have a way out with all the problems that we have currently. Thank you so much for the platform to showcase the beautiful talents we have in NONSA. And to our capacity dogged president, my capacity president, I'm your boy, I'm the lower president, you are the big one. To the Canadian president of all nurses, thank you so much, ma, for the support. In fact, you've been online from when we started till now. That is just to show a sign of sportsmanship and to show that you're really interested in what we are doing. And this goes a long way to actually show how you carry your people over there, how important they are to you. Thank you so much for also the support for the other badges. We really do appreciate, and we look forward to more collaborations and also working together. On behalf of the national body, I myself and my team, we have the team. Also, we have other judges here also, like from Nigeria here. We have Nurse Bright, we have Nurse Tega, and we have Nurse Favor. They've also been on the call. They've been going and coming also. Thank you all also for joining. So also the other judges from Canada there also, thank you so much. I really do appreciate. On behalf of the body, we really do say thank you. And to the participants, just like Mama have said, we are all winners. You all are all winners. Understand? And don't just take it as let's say a normal competition. Take it as you have provided a solution to a problem. I tell people, in everything you do, always be a solution to a problem and not a problem to be solved. So it simply means that you've been able to come up with some things, and those things that you've been able to come up, it would only be wise you put them into action and see how we can use that to also enhance and take the nursing profession higher and better than the way it used to be. Once more, thank you very much.
Yeah, and I also want to appreciate Uche for also pushing for this. And thank you, Chioma, for coming. So, like I said, just give us like 5 minutes for us to be able to come up with the winners. Then we'll come back to you shortly.
Okay, in the meantime, if you have anything to say, any contribution that you were not able to say during the calls or during the presentations, you can just leave it in the chat, or anything that you want to say to any of the judges or anybody on the call now, you can just leave it on the chat. The three dotted icon, click on it, it takes you to a display where you will see in call messages. So whatever you want to say, ask, anything at all, just put it on the chat. Mm-mm.
While we are on this, can somebody just come up with a joke so that the house doesn't just look boring?
Okay, I'm going to share my clinical experience in neuropsychiatry ward because I think it's very funny and you guys might laugh. So my name is Ojuma Manuela. I don't think I introduced myself before I started the meeting. When I was posted to neuropsychiatry, I actually was posted to the male psychiatry ward, and I don't know if people can picture it, but those of us that we are here in Nigeria, we know how the ward is. For the male psychiatry, when you enter, the warden has to come from inside and open the door for you. And the way we have ours here in Uniport, there's like a straight path where you walk down to the nurse's room and you keep your bags. So I always go very early. I like to be punctual. So myself and my friend Rose, we are supposed to be there by 8, but we got there around to 8. I think few minutes to 8. So we're the first set of nursing students to come. And they're like, oh, okay, how can we help you? And we're like, oh, we're posted here. We're having our rotations. And the warden opened the door for us. So we entered. Then he had to close the door. And we're like, oh, where's the nurse's room? Because the nurse's station, there were no nurses there at that time. I think they just did their handover, so they were probably changing inside. So he told us just walk the path down. So mind you, that path that we're supposed to walk down, they have rooms by each side, and these rooms have 2 doors each. So it's like they can cross from left to the right hand side. So as we're walking inside to the nurse's room, some of the male patients started coming out from the room, and one of them was like, God have mercy. One of the male patients said, these nurses are fine, you know. Mind you, I'm not so tall. Rose is the taller one. She's about 5'9", 5'10", so she was behind me. And she's like, Emanuela. She was kind of nervous. Well, I tried to keep myself in check and appear overall calm and not show that, oh, I'm nervous. And then one of the patients came and said, Omo, I would like rape this one. Oh. That was when myself and Rose, we just froze there. Like, we could not move. We just stood and the warden had to come and be like, what's that nonsense you're saying? Come on, stop saying that. And then they just shunned him. And they just start, they were like, they were, I will not say they were like ox. They were just looking at us as if we were prey and they were predators. But then we walked inside, dropped our bags, and then went to the nurse's station. So the nurse's station is, they have like a burglary where you can see from the station, but then they can see you, but then they can't come in. So there's like a demarcation there. So then we sat down, and then the male patients, they're trying to get our attention. Student nurse, fine girl, fine girl. We're not responding. At this time, we're like about 17 of us because we're 20 posted there at that time. But 17 of us had just arrived. Yeah, it was a full, we're plenty excited. We didn't know. So most of the patients that were there, most of them were there as a result of drug abuse. And most of them, I was so surprised that they were speaking so well. They were quite educated. Contrary to popular belief, they were very much educated. So they were trying to get our attention. Student nurse, we're not responding. Me for me, I was not responding. I was just like keeping a straight face because my friends and money was like, don't be too familiar with these people. If you don't want to be spoken to anyhow, or something like that. And then one of them just started shouting, "Who opened the gates of heaven? Who opened the gates of heaven?" And we were all looking. We stood up. Where is he about to have an episode? Is it a crisis? What's happening now? Started shouting, "Open the gates of heaven! Open the gates of heaven!" And next thing is like, angels escaped. Look at them here. Oh my God. It said angels escaped. Look at them here. Look at them here. And we started. Me, I didn't want to laugh before. I already said I was not going to laugh. But I could not help my laugh. I was laughing so bad. And then it's like, see, you're smiling. And then they just started talking, what's your name? I wanted to lie because, and I'm like, no, there's no point because you literally have your name on your uniform. So before I could even respond what my name was, he already called out my name. And I'm like, oh, okay. So it was when the head nurse then came in. She was like speaking to us about them, that we should speak to them, that they're normal people like us. Because they are on the other side does not mean that they're less of humans, you know. We should not treat them because of their, we should not identify them with their disease condition, but we should see them as human beings. We should interact with them. So that was when some of us loosened up a bit. They were just standing by the burglary proof, like trying to talk to us. So we started talking to them, how are you doing? So it was until it got to medication, when we were about to give medication, they started coming inside the nurse's station, and then they'd have to take the medication there to engage them in conversation to make sure that they are taking the drug and then they didn't hide it inside their mouth or something like that. If somebody wants to join, go just a minute. So after the medication, yeah, oh, I'm so sorry. After the medication, the doctors then came for ward round. This is where it got really, really eventful, I'd say. So when the doctors came for ward round and the nurse in charge encouraged us to join them,
Sorry,
for the
can I
ward
get the
round.
name of the nurse who spoke on bullying?
Oh, I think it's she's not here. The Abdullah. She's here.
Is it Sabiat? Is it Sabiat?
Yes, yes.
Sure.
Okay, so if you're interested in my story, if you want me to continue, please just drop an emoji. Of course. Okay. So when the doctors came and then it was time for ward round and the nurse in charge encouraged us to join them, I was a bit skeptical. I didn't want to, because we have to go inside the ward where they are and all the beds, all of them there. We went inside. We were quite a number, and then two doctors actually. So me, I was behind because I already said that one of the patients was trying to get my attention, and I was not responding until they started shouting, "Who opened the gates of who opened the floodgates of heaven?" So when we entered, my colleagues, my friends, some of them said, "Oh, that particular patient looks like Burna Boy," and I'm like, "Are you people being delusional? I don't see any Burna, no talk of the boy there. I don't see any resemblance." And they're like, "Ah, Ella, you know, see?" I said, "I'm not seeing it though. This one, I'm not seeing Burna Boy. I've forgotten the patient's
Sorry,
name. But
who spoke on lupus?
Ma, sorry,
Who spoke on
Who spoke on
lupus?
lupus?
who spoke
Can
on
I have the
lupus,
name,
Can I
please?
have
please?
the name, please?
Zemira Somailama.
Zemira. Zemira.
Samaila.
Skamila.
Yes,
Zemira.
ma'am. Yes, ma'am.
Is Zemira
Is
different from
Zemira different
Samaila?
from Samaila?
No, it's it's
Yes,
it's
ma'am.
it's,
Yes,
it's
Zemira
together.
Somailama.
It's one person.
Okay.
Okay.
Okay, so when we entered the ward, we started with the patient that they said looked like Burna Boy. So the doctor started asking him how he was doing, how he was faring, if he was taking his medication, and he was responding. He was even telling the doctor about his sister and how his dad is disappointed in him, how his dad has forgotten, does not want to involve himself in anything that's going on with him. And then he was like, "Oh, doctor, I see that you people have new nurses." And doctor's like, "Yeah, we have new nurses here. They are student nurses. They were just posted." And the doctor's like, "Oh, is anybody that you like?" I still don't know why the doctor would ask such a question because we are students and I don't think that's proper. But the patient said, "Yes, there's somebody that he likes." And doctor's like, "Who is that?" And he said, "Emanuela, Nurse Emanuela." Mind you, I was behind. And then they were like, "Who is Nurse Emanuela here?" I was just standing behind. Then they're like, "Ah, Nurse Emanuela, I didn't know you want." I say, "Ah." And then the patient's doctor is like, "Speak to him, talk to him. He's normal." I'm like, I started speaking. I said, "Good afternoon." Mind you, this was like 300 level first semester, so we're still new to. This was my first time in psychiatry ward, and we had not even been taught mental health at that time. We just started. We had not really gone far, so some of the things that we're seeing there were very new, and we're not conversant with them, so to say. So we still had like some of these beliefs or misconceptions that people have outside. We still carried it with us to the ward. But like now that we've learned so much more better, I think maybe my approach would have been different then. But that was very awkward and very, very eventful for me because I had to now go in front of like all the students and then started saying what I do not know. How are you doing? How is A, B, C, D? Things that on a norm, if the doctor had not called me forward, I would never have done that because some of these male patients are believed to be very, very aggressive when they are having their crisis. That was like one of my experiences there that I think is very eventful. I like to share it to people. Should I share another story? I'm having fun.
Go ahead.
Go ahead.
Oh, so still mental health, still psychiatry ward, that male patient, male ward. There was a particular day that we went for. I think it was afternoon shift, and then there's this boy. He was around 21. He had just written his jam, but then he had not gotten admission, and he started taking, I think, colos. He started with colos and went on to ice. And funny how these patients, they know what they did or they know what they're doing, and they just cannot stop because they were trying to engage us in conversations. It was very, very aggressive, that particular patient. And then his dad came. His dad was a very elderly man in his 80s or so, and the way they did that ward, the male mental health ward is upstairs, so you'd have to climb like so many stairs to get there. And see how his father was struggling to climb because he's an elderly man with his walking stick and was struggling to climb the stairs to come up and see the boy because that's his last child. So when the father came in and they brought the boy from the ward to see the father was like, "See what you've done to yourself." The man was lamenting. Initially, the boy was sober. He was not saying much. It was more like he admitted that he was in the wrong. So he started asking his father for money because they give them money because there's a woman that comes to sell food to them. So the woman comes every morning, afternoon, and evening, gives them their food, then they pay. So some of them have money that they used to pay. So he was asking the father for money, and the father was like, "Last time I came here, I gave you some amount of money. How come you've exhausted all of that? Is it not just food that you are buying here?" And that's when he got very aggressive. That his father is like started abusing the man, calling him names, telling him that he's going to beat him, that once he leaves here, that he's going to beat him, that the drugs that they're giving him here is messing with his head, that these drugs they are not good for him, that he should ask any of the like other patients that these drugs they're not good for them. He was about to get like physical with the dad, so the nurse had to step in and told. So they have like a, let's say, in charge patients in the ward that all of them they kind of respect. So the nurse was talking to that one to speak to him that if he does not speak to his friend, she's going to give him something. So he was still not listening. The other guy was trying to speak to him, say, "Calm down now, calm down. See elderly man when you're distressed, blah blah." He still was not listening. So then eventually they gave him, I think they gave him 2 shots. I don't know if it was diazepam. I don't remember what they gave him, but they gave him 2 shots because apparently he has he has built some resilience. The first one did not do the job. They had to give him another one, and then he still refused. Like he was trying to fight the drug. They see him staggering and trying to walk around. He was not letting his body relax. So there's this particular patient amongst all of them that is very very calm. He's very calm. He doesn't interact. He does not. He has gone to rehab twice. If you hear him talk, you know that he knows that he's not supposed to be there. Very, very educated. I think he was a medical doctor. I can't remember very well. Very calm. He knows what he's doing and he needs to stop, but he can't help himself. So he was just watching. And then we saw the boy, the particular boy, the 21-year-old boy that they gave the 2 shots. He was just looking, and then the other one just shouted, "Boy, you don't listen. Now you're gonna miss lunch, you're gonna miss dinner too." Like the way he said it was so funny that everybody started laughing, like, bro. Like at that point in time, they were telling him that he's going to miss lunch and he's going to miss dinner too. Like, bro, you'd have just listened and behaved yourself. And then the father was so sad. In that moment, I saw that the damage that drug had done to so many Nigerian youths, because even nowadays it's even worse that people that are not up to teen, they are not teenagers, they even have access to these hard drugs. Now, so Alexis, is it time? Is
Can you hear me? Can you hear me?
Yes, ma.
Is Oluwatosin different from Abdul Malik? Sorry, different from Olayinka.
I'm coming, ma.
No,
I'm trying
ma.
to check.
Oluwatosin Olayinka is the same person.
Okay.
Okay.
Okay, so I can't remember any story that I'd like to share. I don't know if anybody has any story that they'd like to share or anything that they'd like to say before the results are announced. Somebody's hand is up. Uche. Chuku. No, it's not Uche. It's, sorry. I don't know if that's your hand. Oh, Ramot Kende. I'm so sorry if I'm not pronouncing your name very well. Ramot, you have the floor.
The lady that
Thank you
spoke
very much.
about the instance of the dad. What's her name, please?
Blessing.
Blessing who? Wano.
Yes.
Yes, ma.
Okay.
So, Ramot, you have the mic, please.
All right,
Alright,
thank you
thank
very
you
much.
very much.
My story
My
is
story
also
is also
relating to
relating to
mental
mental
health
health
practices,
practices,
but this
but
story
this
was
story
told
was
by
told
my
by my
lecturer.
lecturer.
So she said, remember the first time she went for mental health posting, and then there was this particular woman who kept looking at her. So she said this woman won't say anything to her, but she sits down in a place and then she'll be monitoring every movement she makes. Even when she goes to the restroom, she'll follow her, but she won't enter because since they're not allowed to enter into the nurse's restroom. But it's like she's monitoring her and spying on her. So she said there was this day, like she more a particular like this particular woman, the special woman, since I don't want to call her a psychotic patient, I'll just use the word special woman. This special woman wore this particular Ankara. So she kept looking at my lecturer, and then she walked up to her and asked her, "Why are you not reacting to this Ankara? Why do you not react to this Ankara?" My lecturer was confused and she was like, "What do you mean by why am I not reacting to this Ankara?" Then she was like, "Are you not the woman? Are you not the woman that stole my husband from me? It is you now. I purposely wore this Ankara today so that you will know what you did. You have done that brought him to this place, this and that." Then suddenly she got physical with her, saying that she not the one that wore the white on our so-called wedding day. Then my lecturer was surprised and was like, she does not even know this woman from anywhere. She's not even married. Then she tried explaining to this woman that it's probably not her, this and that. But she suddenly started wanting to like get physical with my lecturer. So they gave her a shot, right? So when she got better, the nurses were like, my lecturer had to ask to her, like he had to have conversation with this woman, because if he did not talk to her, this woman is going to keep thinking that she's the woman who stole her husband from her. So when they had the conversation, then the woman now noticed that that is true, that she's not actually the woman, because the so-called woman that stole her husband from her has a mole at her neck, and this my lecturer doesn't have the same mole. So the lady apologized to her, but she was like, if she has met her outside, that she would have killed her. So that's just my story. Thank you.
We'll soon get back to you, okay?
Sorry, I got off the call. Ramot, are you done with your story?
Yeah, I think she's
Yeah, I
done.
think she's done.
Does any other person have anything for us? We'll get back to you in the next 2 minutes.
I have something to say. Can you guys hear me?
Go ahead.
Okay. So my own experience was I was in male surgical ward actually when I was in 200 level. And the nurse on duty, they were two actually. Now, the reason why I remember this experience is this. Both of them were talking and laughing. Then one went inside. So while the other one was outside, there was a man there that had broken bones and ribs and everything due to a road accident. His brother came and his brother was speaking to the nurse that he wants to see his brother, he wants to see his brother that had an accident. And then the nurse was trying to explain to him that this is not visiting hours, you can't see your brother now. And then it became a matter of pride. And before you knew it, they started exchanging words. And then that nurse that was there was somebody that you can just talk to anyhow. She'll give you back to back too. And do you know what happened? When they started raising their voices, the other nurse that she was laughing with came outside, saw what was happening, and then she just, I don't know, she stylishly disappeared. She just went inside. I know that nobody noticed it, but it was something that I observed very well. And the moment they were done with fighting and all of that, she came outside back to come and ask what happened. So the whole thing I got from that is that nurses know how to, like, I don't know, defend yourself when it's time to defend yourself. Like when it's time for trouble, just disappear. Because you might have to give report or all those kind of stuff. I don't know why she did that, but it's just something that stuck with me. Like you didn't even come to defend your friends. You just like, I mean, there might have been a reason for it too, but I don't know why she did that. Maybe you guys know. That's my own experience. That's your nurses. Every man for himself inside each ward, every nurse for himself. When it comes down to it, it's you that will go and give your own report, or it's you that will go and defend yourself. Everybody will disappear. That's just what I got from that experience.
Yeah, I agree with you, Uche. There's something that they used to say that the nursing profession is a dog eat dog profession. I hope that's not true. I refuse to believe that. But it's a very popular saying that the nursing profession is a dog eat dog profession. Where people will just decide to or pretend to not be aware of whatever is going on. I don't know. Well, I've not practiced yet, so I can't really say.
I beg to disagree because I love nursing and I love nurses and I love to fight for nurses.
Ma, it's not everybody. Oh,
Especially since I use my two eyes to see.
ha. It's not everybody. Oh.
And this is Nigeria also.
This is Nigeria.
Like
Not
if
just
she did that
Nigeria.
thing, like you won't even know. Like she didn't do it in such a way that you would have observed that okay, she's not defending her friend. She just disappeared like a
And
ghost, and then she came back later.
they're also quick to throw their colleagues under the bus too. That's one I've also seen in the hospital. They're very quick to point at. Oh, I don't even know. Oh yeah, we're not going to be those kind of nurses, Sha.
Better.
Does anybody have any story for us or any contribution, anything to say before the results are announced? So everybody here already
Ma'am,
won.
everybody's heart is beating. Am I part of the first five? No, their mind is not even on what we are saying instead.
I think that's why it's just myself and you speaking because we did not present.
That's true. They are not even
But
concerned
I've
what we
been
are saying. Everybody
speaking since now, and I'm still speaking. You both should talk.
nothing for you. Nothing for you, my dear.
No, I know. I'm just saying that they should loosen up themselves. Because if you worry, the results still going to be called and it's still going to be the same thing. So you worry, you gain nothing from worrying or stressing over a result that is being decided on. You really have no input right now. You've done your best and believe that is good enough. Dora, you have something to say.
Yeah, actually, I might have something to say.
Okay, please go on.
Okay, so about that experience, that postpartum hemorrhage I wrote about, it was actually a very terrifying experience in the sense that by the time the doctors came to attend to the woman that was bleeding, that had the hemorrhage, there was a lot of blood clots. Like they were removing large blood clots. And this particular patient, she hasn't been able to get pregnant for, I think she was like 45 or so. This was her first pregnancy. So after the delivery, the woman was literally happy. She was thanking God and all of that. Meanwhile, she was bleeding, but definitely she will not know at that moment. Plus, she's already on pain relief and pain relief and all of that. So in my mind, I was like, God, why this woman is rejoicing? She's happy about her gifts from God. Another thing is happening to her that she's not even aware of like this. So, and according to this policy in that hospital, nurses do not carry out such procedures. Though I know nurses are supposed to, like midwives are supposed to be able to do something like that, but they couldn't. So by the time the doctors finished attending to this other woman that has that lacerations and all, rushed the patient, the baby to ICU. This other woman was going, her uterus was not contracting like the way it's supposed to again. It was like very high and strong. They started removing the blood clots. One of the nurses, one of the doctors that was there, she nearly fainted actually. I was one that had to go and bring coke for her. She nearly fainted. So they tried everything they did, and I guess they stabilized the patients because when our time for that unit was up, we had to go to another unit. So they stabilized the patient down. Or there was actually even one more hemorrhage case like that. That the woman was covered. She was after the post delivery care and everything. They were waiting to transfer to the recovery ward. But this woman was actually bleeding. She had an internal tear that they didn't see after the whole delivery and everything. They didn't notice it on time. So her pad was actually filled. They have even changed one before. So maybe they thought, okay, that fetched one. Okay. So the second one was already filled. And as a matter of fact, the bed mat that she was lying on was filled with blood already. But because she covered herself with a wrapper, we didn't know, like nobody noticed on time. So because of space, trying to admit new people and all of that, when they said, oh yeah, let's take this one to the recovery room, that was when they noticed that this woman has been bleeding. And I noticed that this woman seems to be weak because I had not arrived, like my time has not started. I was not arrived the ward before this person gave birth. I only came in after they have taken care of her and everything. So they opened her wrapper to transfer her now. They saw that there were lots of blood, like blood everywhere. This woman was literally going. She was initially calling to get her sister inside, but because the field is a kind of sterile field, they cannot actually just allow her sister in, not knowing that she was actually sleeping off. So that was how they had to attend to her after they have finished with this other emergency. So at the end of the day, it was like doctors are doing almost everything when the nurses knows they can do this thing, but what can they do? I sure heard like from my previous colleague that went there, I heard that there was a particular doctor that was on duty during her time that the nurses actually worked while he was on duty. So it's more like they cannot actually work well, like they cannot actually put their knowledge to work when there are many eyes on them, like that kind of thing, because of hospital policy. But when there are lesser eyes, okay, maybe something like that, they can just try and do one or two things. And these things literally affecting nurses because some of them now, instead of focusing on research, knowing more things and all of that, they are literally they will not channel the energy into hierarchy kind of something, discrimination and stuff like that. Sure, they are actually good nurses, so, and I actually felt pity for the kind of way the profession is being handled due to policies and all of that. But thank God, because when I was small, when I was like halfway, my mom actually had a situation like this. But so it was more like two contrary character kind of nurse that was attending to my mom. While one was somehow, the other one nurse was very, very nice and all of that. Well, thank God, sure. Yes, that was like it. Thank you guys very much.
Thank you so much, Dora, for sharing that story with us. That was very emotional and sad at the same time. I'm thank God that the woman did not die, but she already suffered damages. And hospital policy is been restricting our nurses. I don't know why, but then again, we hope to be change makers because I feel like one of the reasons why some hospitals make such policies because some of the will I say some of the then nurses or some few nurses might have been incompetent, might have
Yeah,
not been able to bear the responsibility. So, and some of them are not even accountable for their actions, and some of them do not even want to take up responsibility. So, because if you take responsibility, you take the blame if something should go wrong. So people that are willing to take responsibility and deliver and know that they are competent and capable. I feel like that's why some hospitals still restrict nurses and all the skills that we learn in clinical rotation, procedure manual, we end up not using any of them. And if you don't practicalize, they're going to actually leave you.
yes.
Very sad. Very, very sad. Thank you so much, Dora. Does anybody
Who is
have
Daminino? Daminino.
Ma?
What's the other name? Who is Daminino?
Okay, Jesu
Mm,
Alaye. Is he Alashe?
Alashe.
Let me check. Alashe.
Uh, can you pronounce the full name?
Jesu.
Is it Jesu Dinu?
Just to do me, yes.
Oh,
Just to do
okay.
me, Alashe. Yeah, thank you.
Alashe, okay.
Very
Okay.
peculiar name. So, does any other person have any story to share or anything that they would like to say while we're still on the call? Okay, somebody's raising up their hand. Ramot. Okay, you can share your story.
Okay. This is not a joke. It's just like an experience that I had when when I went for posting in the labor ward. Okay. So there has always been this thing that like I noticed in labor ward for like pregnant women that I'm seeing, especially the first timer. They always like screaming and sometimes, as I've said before, pain is subjective. You cannot always say your patient is over exaggerating about their pain. But the way nurses react to those patients, even doctors, is always very sad because they're always like shouting at them and like, shut up, am I there when you were doing it? When you open your leg down, was I there? This and that. And then I remember because for our posting, we're always assigned to a patient. So for my patient, the person I was nursing, since it was yes, I was nursing her. So she was in pain and she was anxious. She was a first timer. So he complained about her back, that she was having backache, and I was helping her to massage her back. And then one of the nurses was like, "I'm spoiling her too much. That why would I be massaging her back for her?" But I was like, "This woman is in pain. He needs this kind of care." So I was like, I can live there. Look, okay, look on. And since these are my superiors, I had no choice. I left this woman. But then she kept complaining that her back is paining her, her leg is paining her, this and that. So eventually she couldn't give birth by baby. She needed tears. So she was even more anxious. She was like, maybe if the nurses had allowed me to massage her back, she would have been able to give birth every day. I explained the situation to her that it's not about the massage, that it's about a baby. Because our baby is bigger than our pelvic, so the baby couldn't come out. So the woman was like, she's not going to go to, and it was already about almost time for we student need to close for the day. And the woman was like, she's not going to go for the CS with those nurses, that she wants me to go along with her. I, the nurses were trying to explain to her that I have to leave, but I sacrificed my time and I told her that I'm going to stay with her. So the CS was successful actually. And then there was this day I was going out and then I saw this woman. She just walked up to me and she was like, see your baby. I was lost and I was confused that my baby. Because I did not recognize the woman because I've lost more than like how many mothers. Then she was like, I was that woman that you helped to massage her back. I was like, oh, hmm. And like this was the idea almost like 2 months after. Like I didn't even remember the woman at all, but she was so happy and she even asked me to carry her baby. She was like, if it's not because of me, she does not think that this baby would have come alive. So for me, I was like, I think we need to like remove this idea of always shouting at our on our patients. We should try to like talk to them more friendly. And because this is even very common in Nigeria hospitals, not even like in labor wards, we see it in even in the trial section when nurses are like shouting at patients and hope. Thank you.
Okay, it's about that time. Are we ready? Do we still have people here? Are we ready?
Yes, ma'am.
Okay. Okay. So first of all, I would like to say again, thank you for participating. And thank you for being among the first 15. You are all winners. And I will be giving opportunity to one of our judges, Chioma Eze, to present the winners. And she's going to call the 5 in no particular order first. The last 5, that's the 5 that the president of the Canadian Nurses said she wants to give something to. Then we would announce what she wants to give to you. Then we'll now move over to the first 5. So if you hear your name after the call, please forward your details to the president then we'll be reaching back to you. And when you get your award, you have to make a brief video appreciating the organizer. It's not easy to come up with something like this, and also thanking your co-participants. So that is the only thing that is expected of you. And another thing again, for us to present that gift, we might be doing it live to present everyone with their, once you receive your gift, then you have to make that video. And once again, thank you all for participating. Over to you, Chioma.
I guess I have to turn my camera on this time. Thank you so much for this opportunity. Thank you, Ms. Alexis. And I really want to appreciate all our participants. I really learned a lot listening to all of you. Great nurses, great ideas. You all have done well. I'm nervous. So I will just quickly go to call the winners. I must say every one of us, we are winners already. For you to have gotten to this point, it's something worth celebrating. And please celebrate yourselves, okay? Post on LinkedIn, post on Twitter, post on Facebook, celebrate yourself, and do well to tag the organizers, okay? So I will start with the last 5. I have Sunday Chibike. Then next I have Elijah. I have Dora Bono Ibo. Then the last here is Oboho Paul. Now to the first 5. So I have 2 people going for the 5th position. I have Olua Tosin, Olainka, and Blessing Wono. Then for the 4th position as well, we have 2 people who worked so hard to get to that position. We have Zemira Samilia and Favor Sadiq for the 4th position.
Ma, please, I didn't get you. I'm so sorry, I didn't get you, ma.
Yeah. He said we have 2 people for the 5th position, Blessing and Olua Tosin. Then we have the 4th position. We also have 2 persons there, Zamira and Favor. Sorry, let's fix that.
Yeah.
Okay, yeah, go ahead, Chioma.
Ma, just check your inbox, please.
Yeah, just, it's fixed, just go ahead.
Then we have
1 second, please. Just hold on, please. Some technical errors.
Good evening, everyone. Um, Sorry, we're just trying to harmonize one or two things. I believe that we're just having some, I think, repeated stuffs and all. But in no distant time, it will be handled. So just give us few minutes, and I understand that the tension is high and all, but not to worry. We're here to ensure that those that have done well are well recognized. And just like we said, everybody here, all you all are all winners and all. So just in no distant time, would make the official announcement. Thank you very much.
Thank you, Manuel, for holding brief for us. So I want to just start over. The fifth position goes to Blessing Wono. The fourth position goes to Favor Sodiq. We have Zemira Samilia also for the fourth position. We have Oluwatosin for the third position. The second position goes to, I want to check, Alaska. I want to be sure of the other name. Alaska.
Halasi, Jesu.
Alasi. Okay.
Jesu Dinu.
Sorry.
Hi, Jesus.
I'm sorry.
Jesus.
Yes,
It's
Alasi
Alashe Jesu Dominion. Thank you very
Jesu
much.
Domini.
Ah,
Please don't
let's just
crucify me. I'm sorry.
let's stick to Alasi.
Alasi. Then the winner. The first position goes to Abdul Malik. Abdul Malik. Is the winner here?
Where's the
Thank you
person?
so much once again for
Sabiyat.
the opportunity.
Yes,
Yes.
ma'am.
And yeah, all thanks to the participants. You all did a great job. It was
so
very, it was
Can we
actually an
can we
insightful
see
one.
you on a video, please?
Sorry?
Sabia, the first five. Can we see you? So the thing is, we got Zamira, Samaila, and Favor as fourths. So what we do when we have a tie, we allow the house to vote on the winner. Okay, so if you feel Favor presented very well, can we have your hands? If you feel that Zamira presented more, can we have your hands up? I think that will, we don't need a tie. We want to cut that tie. Over to the house, please. Can we have your hand?
Please, I feel. Hello, ma.
Yeah, go ahead.
Hello. Yes, please. There was a tie with the fifth position too, right?
No, just the fourth position.
Oh, okay. Please, what was the title of what you guys presented on the game so that we can remember?
Okay. I presented on LD competition among healthcare workers.
Okay. And Zamira?
I presented on bridging the gap, not-led approach in improving patients' care.
Okay. Can you both put on your cameras? Can you come on video? Okay. Just the both of you. Favor and Zamira. Yeah. Favor and Zamira. Okay, so please let's vote because that qualifies them for that position. If your vote is going for Favor, let's see your hand up. If your vote is going for first for Favor, let's see. If your vote is going for Favor, moderator, are you there? Please help us count the votes. They both did very well. Is anyone counting the votes? President, are you there?
Yes, I am. I'm counting it.
Okay. Can you see the hand?
Can you see the hand? Yes, I'm calculating it.
Okay, so how many people do we have for favor?
3 persons.
3.
Four.
Yes.
We have 4.
Okay, 4, yes, Elisha, 4.
Okay. Zamira. How many people are going for Zamira? Okay, so how many people do we have for Zamira?
Zamira, we have 2.
2. We have 20 people on this call. Please, let's vote.
Zamira, 4. Favor, 4.
Okay, so they still want you guys to decide. So what do we have total, the president? What do we have? Do we still have 4-4?
Yes, we have 4-4. Favor 4, Zamira 4.
Immaculate raised up her hand for me.
Oh.
Yeah.
For Zamira?
For favor.
I actually feel we should have the voting again. Anybody that wants to vote should vote now.
Okay, so let's go now. If you want to vote for favor, let me see your hand up. Please, everyone should participate in the voting.
After now, won't count. So if you are voting, vote now.
Use the hand icon, Immaculate, not thumbs up. Use the hand icon. Those
Like
3
you're
dots
raising up
there.
your hand. Yeah.
Immaculate, use the hand icon, not thumbs up. I don't think that person knows how to raise their hand.
She cannot raise her hand, but she could put it in the chat box, which is voting for.
Okay, Immaculate, if you can't raise up your hand, please just send
indicate who you're
a message.
voting for.
Yes. Once you send, we'll be able to count.
She has done that.
Okay. So
that means we have six.
Six
For
for favor. Okay.
Yes.
Okay. So let's go for Zamira.
How many for favor now?
6.
So let's go for Zamira. Who's voting for Zamira? 1, 2, 3. Can we have your hands up, please, if you're voting? Zamira, how many do we have now? How many do we have? So
Zamira going and going. We have
Gone.
5.
Is it gone? So how many do we have?
We have 5.
5. Okay, so what is going to happen is we are going to make some adjustments to the prices because it was really very difficult to get to this stage. President, hope you agree with me.
Yes, ma'am. I'm in support.
Okay. So what is going to happen is the first position is going with 120,000 naira. Let me see your face, please.
I'm here, man.
We are not seeing you, Jesus.
I can't see. If I'm not seeing your face, I am taking back that slide. I'll personalize it.
Let's see your face now. I'm sorry, you are representing which school?
Do us a privilege of your face.
You're representing which school?
University of Ilorin.
Ilorin, that is the West, right?
Yes, sir.
Okay.
Okay, so Sadia, congratulations. Let's give her a hand of applause.
Thanks so much. Thank you.
Okay, so you're also welcome to participate in our game. It's coming soon. Zamira, I want to see you in that group. I know you will do it. You all tried very well. So Zamira is also maintaining that position. So what is going to happen is, President, the 4th position was supposed to be what?
Let me confirm, just a minute.
Okay.
The 4th position is supposed to... The 4th position is 40.
40. Okay. So what is going to happen? The first position gets the 40. Then Zamira is going to get 30,000.
Okay.
Okay, so put it down there so that you don't forget. Then the 5th position is also supposed to have how much?
30,000.
30,000. Okay. So the last time, the Canadian Nurses Association president is giving a sum of 20,000 each to everyone. The last participated. Then the second position is going home with 100,000. The third position is going with 80,000. Right?
Yes.
Okay. So let me see the president is here for her to give me a word of advice. I think she said she's joining.
Upon the greatest.
So yeah, I think the first position, over to you. First first. In fact, the first fifth, what is your word of appreciation, advice? Go ahead.
The first runner-up, let's hear you, please.
Okay. Good evening, everyone. Seriously, yes, I don't. Thank you so much. Thank you so much for the initiative. I really appreciate. I don't picture myself winning tonight. Really, I don't know. Thank you so much. And all the participants, everyone tried, as they've said, we all tried our best. Thank you, and may God continue to guide us and increase us in more beneficial knowledge. Thank you so much. I'm really grateful. Seriously, I'm really grateful, and I'm very, very proud of us for participating till the presentation and everything. It's not easy, but we've come this far. I appreciate it. Thank you so much. Thanks.
So I think the Canadian Nurses Association president is here, so let's hear from her. I'll get you over to you.
Okay. Oh, this boy is even here talking. Okay. Hi everyone. How are you all doing? Good. Okay. That's perfect.
Fine.
That's perfect. Awesome. Thank you so much for that's so beautiful. That's lots of reaction. That's beautiful. Thank you so much for taking part in this. As I said initially, I don't just want you guys to take this as just a competition, because from what I've seen, from what I've heard, and the passion with which you presented, it's the authenticity of your presentation. And these are real issues, they're not fictional, they're real issues. And if we've identified real issues, we can start making changes one step at a time. So let's collectively and individually think about how to move these recommendations from ideas into real life solutions. And we can all do that. And that is what is really identified right now is the future of nursing in Nigeria. Really, that's the future of nursing in Nigeria. So let's take it like that. Let's take it as we are you guys are the generation to make that impact, whether we are away or we are home. They talk about brain drain with all of the healthcare professionals moving outside Nigeria, especially nurses. But we try to look at it from brain circulation. And that is what Alexis and the Dynamic Nurse Initiative, that's what they're actually symbolizing, that you can find a way to recirculate that knowledge, that brain, so that it doesn't just go away and stay there, but bringing back that change that we've seen and we've come to embrace, bringing it back to the land that actually gave us so much by training us and helping us to become what we are, even though there's still a lot of things to be saved at, but we can't take away the credit away from them completely, because they trained us, they built us, they made us who we are. So thank you so much, Alexis, and all of the organizers for even thinking about this thing, and not just allowing it to be an idea, bringing it into reality. Thank you so much. I can appreciate, really, because I know organizing things like this is not easy. It takes a lot of your time, a lot of your hours, a lot of your initiative. So thank you so much for doing that. And also I see the integrity in the process, and that's also part of the accountability and the trust that we are hoping to continue. Okay, that we hope to continue to build. So thank you so much. And again, back to the very intelligent participant. It was really refreshing to see the caliber of nursing students that we have. That gives me a lot of hope. It gives me a lot of hope to know that we can actually come back home and do something. Thanks so much. God bless you all. And as I said, I'm going to keep in touch, but I don't know how though. But I will find a way. Okay. Thank you. Thank you.
Thank you so much. Yeah, we can all keep in touch. We go bigger next year, and not just next year. We have other projects that are coming up this year, like I said. So just keep you get updated from the NONSA presidents, and yeah, we'll take it all from there. Thank you very much. It was a great participation, and you have all proven that you are not just going to school, you allow school to pass through you while you are passing through the school. You did so much, so well, and I'm sure that everyone listening to you will be very proud of you that you participated. For everyone that participated, whether you're a winner or not, as long as you go to this stage, like I said, we had 120 participants. So for you to get to this stage, you're already a winner. So don't take any of the results to heart, but whatever we have talked about here, find a way of moving it into a policy stage, not just the talking stage. Let us all work together to make nursing in Nigeria work better for every one of us and our families back home. Thank you so much. So now we over to the second person. Is the second person still on the call? The third person?
I'm so sorry, ma. Did you say the second winner?
Yes, the second winner. The second position.
Thank you very much, ma'am. Okay. Oh, thank you very much, ma'am. Okay. Good evening, everyone. My name is Dominino Alashe, and I'm representing Afro University, and I just want to thank the organizer of this great initiative from Nurse Alexis. I just followed you on Instagram. Honestly, I love what you do, ma'am. Thank you so much, ma'am. And also to Nurse Ogechi Owaneri, thank you so much for your time, ma'am. Thank you so much for your word of advice that you've shared with us. I would not forget them. Thank you so much, ma'am. And also I'm just so proud of myself, and also to my great university for, I mean, even not for them, I would not have the opportunity to partake in this beautiful competition. And at the end of it all, I give all the glory back to God. And I don't know if this is a bit out of place, but currently I serve as the president of the College of Medicine for my school, and honestly, I would really, really wish to stay connected to both you, Nurse Alexis, and also Nurse Ogechi Waneri for future collaborations like webinars that we have here for our medical students and nursing students in general. So I don't know how to be about that, but honestly, I want to start seeing you guys as role models, because you guys are like people that we are looking up to in this profession, and with you people by our side, I'm sure nursing is going to go greater and greater and greater. Thank you so much, Ma. Thank you so much, everybody. Good night. Thank you.
Thank you so much. Third position. So for reaching out, you can go through the non-SAP president and you'll be able to get through to me. Okay. And we are all open, for me and Ogechi, we are open to collaborate with any of you, whether your individual schools or as a national thing, we are open to collaboration. As long as it concerns the students and the Nigerian nursing. Okay. So third position is Oluwatosin. Are you here?
Yes, I am here, ma. Good evening, ma. I was not
Yeah.
sure what my position was. Thank you. My name is Oluwatosin Olayinka. I represent the University of Ibadan from Oyo State, the place where people like to call the first and best university in Nigeria. I am a final year nursing student, and when I entered my final year, one of the things that I wanted to do was to gain more capacity, was to build capacity to be able to serve in leadership role in nursing when I leave the school. And so one of the things that I wanted to do was to engage in things like this. And unfortunately, there are not many opportunities like this outside. And it is just amazing that some people still stand up to empower nursing students and challenge us to think critically and contribute to the future and to the things that we can do better. So I am very grateful to everyone that has made this a wonderful night, to the participants, to the judges, and to the organizer, and especially to the prize that we were not looking forward to that was added. We are so very grateful. Thank you so much.
Thank you very much. The fourth position was the
Yeah,
Favor and
yes,
Zamira.
ma.
Go ahead.
Yeah, I want to say thank you, ma. Thank you for this kind initiative. Thank you for helping us sharpen our writing skills. Like we're able to do something beyond nursing, beyond clinical stuff. Thank you, ma. Thank you, nurse Kogechi. Thank you, Nunsa. Thank you for this beautiful collaboration. And thank you for the prizes too. So thank you so much.
Okay. Zamira?
Yes, ma. My name is Emira Samaila, a 200 level student from University of Abuja. Thank you very, very much thank you very much, ma, and all that organized this wonderful event, because this is the first time I'm doing something like this. So it has opened my understanding, that helped me to make more research and more opportunities, and that I hope to engage in more. And thank you very, very much, ma.
You're welcome. So over to Blessing.
Thank you, everybody. My name is One Blessing Kilichi, 500 level student of Abia State University. I'm deeply grateful to be among those that were selected the fifth position. I sincerely want to also thank the host, Dynamic Nursing Student Initiative, the judges, the organizers, everyone that made this opportunity possible. Thank you. Also, I want to say that this experience has actually inspired me, and I was not even expecting that I'll be part of the winners, but I give God all the glory. Also, I also want to thank the president, the Canadian president of Nigerian nurses. Thank you so much. Thanks to everybody, the NURSA presidents, even my fellow colleagues. Thank you so much. Thank you. Thank you.
Thank you. So we come to the end of this program and this year's Dynamic Nurses Skills Initiative, empowering student nurses. So we look forward to doing this again, and we hope to collaborate with any one of you that feels like you want to collaborate with us. We are open to mentorship. We are open to supporting each and every one of you the best we can. We have platforms where we educate nurses on everything concerning nursing and also migration. So yeah, we are open to collaboration. That is just all. So don't see this platform as the end of it. This is like a beginning to a future that is brighter for every one of us. Thank you all for participating. For my very elegant moderator today, I forgot the name again. Thank you so much for being there and taking out time. And Uche, thank you so much. I worked with you and it was nice working with you. The NONSA president, I think we will do more of this, and the next time is going to be bigger and a better platform for every one of us. Thank you so much. And we look forward to collaborating with every one of you. And thank you. I think we have shared the social media handles. I think the president will also share that. Then please do where to follow and also invite your friends while we participate and collaborate with every one of you. We are open. If you want us, just reach out to us. Thank you.
Thank you very much, ma'am. Thank you very much, ma'am, for us the opportunity for our student nurses to showcase their talent. Thank you so much for believing in the process. Thank you for believing in the team and also believing in us. So our amiable judges are, without you people, we won't be able to go this far also. Thank you so much for the sleepless night, the time and all to put up the results and everything together. We sincerely do appreciate your effort. Thank you so much. And to our leader and also our mother here, who happens to be also the president of the Canadian Nurses. Thank you so much, ma'am. We got your message of the support for the other 5 students non-site. Thank you so much. We got your support from Nurse Alexis. Thank you so much for believing in us and also wanting to support the initiative and also support the student community. We look forward to working more with you and also with Nurse Alexis in all ramifications. Thank you so much and God bless you.
Thank you and good night, everyone. While we are just starting our afternoon here.
Good night, everyone. Good night, everyone. Thank you so much.
Yeah.
Good night.
Good night and God bless.
So that might know, like we are in there to provide. We then feel like in Jesus' name, and then that's
Uche, hello.
Hi.
Blessing, no one go again. No. Blessing, go now.
Blessing.
Blessing, go now.
Blessing.
I beg now, yeah, go now. Just go. Thank you. Thank you so much, Uche, for your work well done. Thank you so much for the sleepless night. I understand you've been busy, exams and all, but you still made out time to ensure that this program is a huge success. Thank you so much. I really do appreciate. To our
Uche,
leader,
you are
man.
such a force. Thank you so much.
Thank you so much. No, she did excellently well.
Thank you,
Thank
Ma.
you so much. To our leader, my helper. I was waiting. No, as they were, all the students were thanking you. People, none of them want to thank me. I was just marking their face. I say, "What I do then? I offend them." But it's fine, Sha. Thank you so much, Ma, for believing in us despite the short notice, and also for wanting to even work with us. We really do appreciate, and we don't take that for granted, man. Thank you so much for the transparency in the process, and also ensuring that at least you carry everybody along. In fact, for you to even expand your heart, you even think, let us accommodate that first person. Some other person they'll just say, no, let in fact they should go. But these people have tried. For them to get to that point is actually something that is worth encouraging. So thank you so much for believing in us and believing also in the process that we could deliver. And we look forward to more collaborations and more workings with you, man. Thank you so much. On behalf of the national body, we must say thank you.
You're all welcome. I think the president of the Canadian Nurses, which I am the president of internationally educated nurses in Canada too. I'm also the president, and we work together. So we are also planning to work together more with you guys. If there are things you can come up with, you can forward to us, then we'll look into it and we'll see how far we'll go with that. Uche, I am looking forward to work with you.
Thank you, Ma.
Zamira, go now. You don't want to go again? Don't you have happy home? Go now, just go. Go now.
Sorry, I don't know who I'm sending my information to.
Don't worry, just go. Get to you. God bless you. Oh, just be going. Thank you. Thank you. God bless you. Finally.
Okay, so you help us get their informations, then we'll forward everything to them.
Okay, ma. That won't be an issue. I think Uche will handle that. So she'll just get the details. No, she will get that. Then I'll just tell the executive they'll put up maybe a write-up to congratulate them the first 10. Then we'll push it out across all social medias.
Okay, so I am and Valentine. Looking forward to working more with you guys. And this time around, we'll make it bigger with more collaborators.
I'm really looking forward. Thank you so much for your.
Thank you, ma'am.
Yeah. Good night.
Good night, Ma.
Good night, ma. From here. Good afternoon over there.
Yeah.